Good morning. Let me try that again. Good morning to you. Good. Good. We're getting a little bit of energy back in here, huh? It's good to see you all here. For those of you who are with us on Zoom, I want to welcome you as well. I just had to give the crowd a little energy in here. I hope that at home you have your own energy. So let me start by saying that the Partnership to Reduce Cancer in Rhode Island has presented over a dozen summits in person. Last year, we did our first summit on Zoom. And this year, we host our first and the first in the nation's hybrid meeting by a cancer coalition. So welcome to you here in the room. Welcome to you there on Zoom. I'm Jim Wilsey. I'm the chaplain emeritus. I had to learn how to say that word when I retired. The chaplain emeritus. I'm a board member of the partnership and the past chair, and I will be your facilitator. So welcome to this year's summit, a decade of promise for pediatric cancer and palliative care survivorship in 2021. Now, I have a few tasks, but my role is really to introduce our speakers and to keep us on time. But for the tasks, let me just say that the exits to this room, should you need them, are on your left and your right and behind you. And the restroom facilities, if you go out either of those two doors, are that way, okay? I feel like a flight attendant whenever I do that. But you can use those. I trust that you're at home, you know your own facilities and how things are. The other thing is, if you have your cell phones here, or if your institution hasn't entered the 21st century, your beeper, please turn that on to mute or vibrate or something where it won't distract our speakers. If you're at home catching this virtually, we've done that for you by putting you on mute. Now, unless you're speaking, and by mean speaking, I don't mean talking at your tables, of course, but unless you're speaking, we'd ask you to keep your mask on as much as possible, just for safety's sake. All right. Now our first welcome comes to us from Diane Martins. Diane is a professor in the College of Nursing at URI, and so she has her PhD degree, so I guess we call you Dr. Martins, although I've only ever called you Diane. But Dr. Martins is the chairman of the board of the Partnership to Reduce Cancer in Rhode Island, and Diane has our first welcome.
Thank you, Jim, and thank you for agreeing to be our MC again this year, which I was very grateful for. Welcome to all of you here to our Decade of Promise in Pediatric Cancer and Palliative Care Survivorship for 2021. It's very exciting for us, as Jim just mentioned, that not only are we able to return face-to-face with you this year, but we also have a 100% virtual conference occurring at the same time. And so this, as Jim has said, our first hybrid conference ever. So we're very excited about that. So we, as an organization, the Partnership to Reduce Cancer in Rhode Island, are very excited for you to be here with us, whether you're here with us virtually or here sitting with us in this room today. And we hope you enjoy each of our speakers, as well as our, what is it called, Susan? I keep going to say our forum. Our panel. Thank you, Susan. So we have a wonderful panel at the end of our program today as well. So welcome to all of you, and I look forward to talking with each of you during the course of the day. Thank you.
Thank you, Diane, and thank you for your leadership. Our next welcome is from Megan Daniel. Megan is the Executive Director of the partnership. And Megan's the best example of the idea that if you're brilliant, well-organized, articulate, a good communicator, and a fast learner, that there's a place for you here in Rhode Island. Megan joined the partnership as an intern in 2019, the first part of that year. And she's been so highly thought of that we asked her to become the executive director beginning this summer. So we welcome Megan to speak.
Thank you, Jim. Wasn't expecting to be emotional this morning. Thank you, everyone who's here in person and virtually for attending the 2021 Rhode Island Cancer Summit. It's amazing to be here back in person after 2 years. And even though last year it was great presenting virtually, nothing can replace being in person together. We've made it through another year of a lot of change and uncertainty, and the partnership has seen a lot of growth and transformation over the past year, most notably with our new staff, not just myself, but our, I can't think of her title, Ashley Aragones, who's in the back, our new board leadership, which includes Diane as our chair, and our new strategic plan, which the attendees here can find inside their program booklets and will be available on our website as well for all of you who are attending virtually. The partnership has also continued to work collaboratively with stakeholders across Rhode Island, and we hope to continue building and fostering these relationships with our community partners throughout this next year and the years to come. So thank you very much and enjoy today's presentations.
Thank you, Megan. It's kind of amazing, all the transformation and the new life and vibrancy of the partnership. Dr. Nicole Alexander Scott has a greeting for us. Now, Dr. Alexander Scott is the director of the Rhode Island Department of Health. I say that in case you're joining us virtually and don't live in Rhode Island. If you live in Rhode Island, you know Dr. Alexander Scott as the face and the communicator and the educator around COVID for the state. Dr. Scott is also, in addition to her work with COVID, very much interested in cancer care and also in palliative care. And so let us listen to her greeting.
Hi, I'm Dr. Nicole Alexander Scott, the Director of the Rhode Island Department of Health. Whether you're attending virtually or in person, I am so pleased to welcome you to the 2021 Rhode Island Cancer Summit. The past 2 years have been challenging for all of us as individuals, families, and communities. This time has been especially challenging for our cancer survivors and their families as they work to navigate the already difficult paths of treatment and survivorship. Throughout the COVID-19 pandemic, the Partnership to Reduce Cancer in Rhode Island has demonstrated its unwavering commitment to reduce the burden of cancer in our state, centering the voices and experiences of survivors in efforts to educate providers, raise awareness among Rhode Islanders, and advocate for the needs of survivors. This long-standing commitment to cancer survivors in Rhode Island continues at today's summit, a decade of promise for pediatric cancer and palliative care, survivorship in 2021. While the incidence of childhood cancers has been increasing slightly over the past few decades, survival rates have been increasing dramatically due to major advances in treatment. This means the population of pediatric cancer survivors has been growing and will continue to grow in the future, making today's discussion of pediatric cancer survivorship and palliative care in childhood and across the lifespan all the more important. I hope that you enjoy hearing from today's esteemed presenters and that you leave feeling inspired with an improved understanding of the issues they'll be discussing. thank you to the organizers who planned this important event and worked hard to ensure that everyone had an opportunity to attend, whether in person or virtually. Stay healthy and stay safe, everyone.
Nice to hear from Dr. Alexander Scott, and I hope you're beginning to feel welcome, whether you're virtually here or here in person. Now it's my pleasure to introduce Dr. Lisa Richardson, who is the Director of Cancer Prevention and Control at the Centers for Disease Control and Prevention. So she's going to offer us some updates, things that are going on around the country. Dr. Richardson's CV is long and very impressive, but when you get the national director who is offered to be here to present and to answer questions from you, you know, if you're me, you get out of the way and let her speak. So, Dr. Richardson.
A cancer diagnosis is a life-changing event at any age, especially for children, teens, and young adults. Today, newer treatments and improvements in care are helping most children live through and beyond cancer. And thanks to the work that's being done at the state and local levels, we're getting closer to answering questions like, why do kids get cancer? And how can we treat each child in the best possible way? Hello, I'm Dr. Lisa Richardson. I'm the director of CDC's Division of Cancer Prevention and Control. I appreciate the opportunity to talk to you about some of the things we are working on to prevent unnecessary suffering and save more lives. Nearly 1 in 300 children will be diagnosed with cancer before their 20th birthday. Cancer is the second leading cause of death. Of those who survive, as many as 2/3 will experience at least one late effect from the disease and its treatment. One of the most powerful tools we have in preventing and treating cancer are data. Data has fueled scientific knowledge and clinical breakthroughs in cancer. Because childhood cancer is rare, data on cancer in children and young adults is in short supply. Findings from adult research are not always helpful in learning about how to treat cancer in kids. Since childhood cancer is so rare, only 6 drugs have been approved by the FDA for children, compared to more than 200 for adults. The Centers for Disease Control and Prevention's United States Cancer Statistics data has all cancers diagnosed in the U.S. since 1999. These complete data on cancer in children helps to guide policies and programs that could help children with cancer and families like Michelle Brown's daughter, Tyler. Michelle is one of many people at CDC with a personal connection to cancer. Her daughter, Tyler, was just 13 years old when a growth was found under her right arm that ended up being a very rare, fast-growing type of cancer. Michelle found herself struggling to find information and resources on rare cancers to help the family understand and make decisions about how to treat Tyler. CDC is working with states like Rhode Island to get data faster, put systems in place that will help us improve the health and quality of life of children, teens, and young adults with cancer. As you know, timely diagnosis and treatment of cancer is critical. It can take up to 2 years for cancer registries to provide treatment reports on cancers, including childhood cancer, to the CDC for reporting. CDC's Childhood Cancer Survivorship Treatment, Access, and Research, or STAR project, aims to give back some of this time to children with cancer and their families. The project builds on CDC's National Program of Cancer Registries' existing procedures and works with central cancer registries to develop a process to collect data as quickly as possible using electronic reporting of childhood, adolescent, and young adult cancers. Rhode Island participated in the pilot program that laid the groundwork for the STAR program. The pilot showed that complete and accurate data on 90% of the childhood, adolescent, and young adult cancer cases could be reported within 30 days of diagnosis. Our partners demonstrated that speed could be greatly improved without compromising quality. The lessons learned from these efforts are helping CDC continue to grow this knowledge base and expand the lessons learned in the STAR project to all age groups. This is an important first step towards achieving CDC's long-term goal of making near real-time data available for all cancers. Faster reporting of childhood and adult cancers will position CDC's cancer programs to be valuable partners in deciding where resources are most needed, understanding what interventions work best, improving clinical trial enrollment, and guiding research priorities. But as you know, every data point collected is more than a statistic. It is a person like Tyler with a story, a family, and a community looking for answers to questions of how they can help their loved ones stay healthy and keep others from getting cancer. Because cancer in children is rare, progress has been slow in many areas, including relieving suffering during treatment and at the end of life. Researchers are beginning to develop new tools like pediatric patient-reported outcomes for symptoms and side effects. There are also long-term studies going on right now to evaluate the long-term impact of cancer on childhood cancer survivors. The National Comprehensive Cancer Control Program partners, like the Partnership to Reduce Cancer in Rhode Island, play an important role in addressing the needs and concerns of survivors today. But they also help drive policy, systems, and environmental changes that reduce the risk of cancer and create safer, healthier communities for the future. Together, we are helping to make cancer history. More and more people are living longer after being diagnosed with cancer. We are all dedicated to improving the lives of cancer survivors, their families, and our communities. Thank you for the work that you do every day to make cancer prevention and early detection a priority and to improve the health and quality of life of people living with cancer.
Thank you, Dr. Richardson. And Dr. Richardson has agreed to answer any questions that you may have. So if you have a question for her as the National Director, there are 2 microphones. Again, my flight attendant stuff. One to your left and one to the right. So if you have a question for her, please stand up and go to the microphones. While you're doing that, I'll ask the first question. We put this together knowing that she had agreed to answer questions. So the partnerships board and also the committee that put together the summit put together a few questions for her. So let me ask the first one in case anybody's moving to the microphone. So Dr. Richardson, given the growing population of pediatric cancer survivors, what can coalitions like ours do to increase access to survivorship resources for pediatric cancer survivors?
So thanks everyone for having me, and I'm really sorry I couldn't be there in person. I think it's what we need to do for all survivors. For children are special, and as I discussed during the presentation, they're all going to have at least one long-term side effect. So I think it's really about learning about it, which we've learned a lot, and also paying attention to what they need and asking them what they need, but also to provide access to that survivorship care and train everyone to be able to take care of people, because once they finish their treatment and move into the community, you know, they see the same physicians that we see. So it's really about educating all of us how to take better care of people who've had cancer in the past.
Thank you.
Mm-hmm.
Okay.
Hi, Dr. Richardson. I'm Terry Mason, and one of our local communities is building a brand new school. Do you suggest any particular agency we should contact or receive advice from to make sure that everything they put into the school could be the most environmentally safe anti-cancer environment?
Yes, I think the main thing is, again, to use, all the approved materials that aren't, cancer causing, which has already been taken care of pretty much. The other thing I think as well is that the thing we don't think of now that COVID has been in everybody's life forever is, are things ventilated properly? And I would say that's probably the most in the old schools, like the ones I went to back in the, the dark ages. Just those types of things, but just to make sure things are open, kids have access to, the things that they need to learn.
So just the HEPA filters, the windows.
Yeah, I
air,
think that for me, I didn't realize before the pandemic that that's really the forgotten sort of thing.
Anti-asbestos.
Yeah.
Okay, great. Thank you.
Mhm. Yes, ma'am. And all those awful materials like asbestos that we used to use, all of those things are not used anymore, so.
Thank you.
Mhm.
And I know one of the things that we've worked on on the partnership was really looking at when children were able to go outside in their schools, how do we provide safety from the sun, whether that's shelter, trees, shade, or putting on skin screening stuff. Another question, Dr. Richardson, considering the lack of treatment options available to pediatric cancer survivors, what can coalitions like ours do to increase access to those that do exist or to increase access to enrollment in clinical trials?
So for young children, we've done a fantastic job with getting them into, I think, gosh, under the age of 14, 90% of children are on clinical trials. So the at-risk group is the adolescent group, somewhere between like 12 and 19. I think they have a little bit more autonomy and license to make decisions. Or we don't think about sending them to children's hospitals, but that's what I would say is the thing that we've noticed in some of our research that we've done is that it's the youngest children get to those centers of care with pediatricians, the older children, adolescents don't, and we need to make sure to remember that we get them to a children's hospital if we can.
Thank you. A big part of what the partnership does is public education on issues around cancer prevention and control. Considering there's really no screening guidelines or common risk behaviors that contribute to pediatric cancers, what types of public education could the partnership provide to help reduce the burden of pediatric cancer? Kind of touched on
I'm
that.
sure some of you, there may be people in the audience right now who have children that have had cancer or people who've survived cancer. I think for us as providers to be diligent about symptoms that children may have that could lead to something. Cancer is still pretty rare in children. I think it's 11,000 cases under, out of 1.7 million. So it's not the first thing that comes to our mind when we see someone in the clinic who is very young, but to be diligent if parents have difficulty or, are concerned about symptoms to pursue, seeing the provider. And I think as we learn more and more about cancers in children that we hopefully will come up with ways to find it earlier. Having said that, since more adults get cancer than children, to really practice those cancer prevention behaviors in children, like exercising, getting outside, wearing sunscreen, not, never smoking or those types of things. So to live a longer life in adulthood, but to just be more aware of symptoms that people have. And if parents are concerned, to persist because you know your children the best.
So we have another question from the audience.
My name is Lynn Basilio. I have a question about the long-term effects of cancer treatment on pediatric cancer patients. You mentioned certainly that they have some lingering effects. What is some of the research or what additional work is being done to try to reduce the impact on future fertility for the young patients? I know that families are certainly concerned for the here and now, but they really do think about and are very optimistic and hopeful that their children will grow and build families in the way that they want. So can you tell us a little bit more about some of the work to try to reduce any negative impacts on fertility?
So I haven't looked this one up in a long time, so I can't give you statistics, but I would say in an older child, a teenager, there might be some, fertility sparing things that you can do. One thing that we're doing in all of oncology is lowering the dose of the medicine to get the maximum effect. Prior to learning about in the clinical trials, which is really good to get people, children in particular, into clinical trials, the dose of medication has gone down. Those things that would cause children to be infertile, we've lowered the doses of a lot of those medicines. We also don't use some of them anymore. It's some of the really, awful ones for causing infertility. And the research that's out there, and I can look this up and send it to Megan, shows that in adulthood, most childhood cancer survivors, if they want children, are able to have children. It's not all, but it is, quite a few of them. And I could send that information if you need that.
Good. We have time for one more question, and we have one more questioner. Perfect.
Just quickly, Dr. Richardson.
Yes.
I know that CDC is a wonderful source of information on their website that I refer to fairly often. And I'm wondering, with this new focus on children, if there's a dedicated website or page for parents to go to find reliable information.
Actually, that's a great, I don't think we have one specific page for that, but that's a great idea. Our web stuff is very, pliable. So I like that idea. So I'll write that down and I'll get with the people who need to get a website. It would actually work and be complementary with the STAR project that I talked about. And I want to thank you guys in Rhode Island for being a part of that. I mean, the stuff that we've learned about how cancer gets reported is going to change the way we do all business at CDC getting cancers reported, because who would have ever thought we could get 90% of cancers reported in 30 days? And we did that with children, and it's going to help everybody with cancer. So I appreciate the work you guys have done in Rhode Island to help us with that. But that's a great idea. So I just wrote that down. We'll get our web people and our special, we have we have a pediatric oncologists on our staff, actually, which is very unusual to have someone like that at CDC. So we'll work on that and get one up in the next, maybe before the end of the year.
Great, thank you.
Not a problem. Thank you.
That's great. Thank you so much, Dr. Richardson. I think it's a great example of ideas coming from us who are gathered that get to the national level. And thank you for your responsiveness to that, Dr. Richardson.
Absolutely. Thanks for having me.
Now our keynote speaker for this morning's event is Jessica Marfio. I met Jessica when she joined this summit as the reigning Miss Rhode Island in 2013. At that time, she said that her goal was she wanted to become a nurse. Wasn't that strange that a Miss Rhode Island, wanted to become a nurse? She, in fact, achieved that goal already. And she mentions that she has a couple of more goals. So we know she's going to achieve those as well as she continues her education. I've also had the privilege of working with her when she was a bone marrow transplant nurse at Roger Williams Medical Center. And now she's a respiratory intensive care nurse at Rhode Island Hospital. So she continues to grow in her expertise. She's also a cancer survivor from a very young age. Just an FYI, I work with her grandma. I don't want to say I'm old, but I work with her grandmother, who was also a bone marrow transplant nurse at Roger Williams Hospital. So I know that caring and compassion for patients is part of her blood. So now let's listen to Jessica Marfio.
Good morning, everyone. I'm just going to take my mask off. I think we can all agree that's probably one of the best feelings we all experience now is taking off our mask. My name is Jessica Marfio, and I am so honored to be back here on this stage. It was 8 years ago I was here as Miss Rhode Island because Kelly Smith read an article about me in the Projo and gave me a call and said, can you please come to the Partnership to Reduce Cancer and speak about your experience with childhood cancer, as well as your aspirations and goals. So back in 2013, I was here. So it's kind of deja vu that I'm back here now with some of my goals and dreams achieved and get to educate and speak with all of you today. So thank you so much for having me. And I do want to say hello to everyone on Zoom. Thank you for joining us virtually. I know I have a few of my nursing families and also my new niece Penelope joining me via Zoom. She's 4 weeks old and going to be a future nurse. So I'm here to talk to you. The title of my presentation is Cancer, Crowns, and Critical Care, How My Cancer Diagnosis Helped Diagnose My Life. And since we do get some CEUs, which I'm so excited about, we have learning outcomes. We're here to identify the challenges current pediatric cancer families and patients face, developed an increased understanding on survivorship needs after treatment, discovered the challenging aspects of grief, loss, and bereavement of patients and families, as well as the loss experience of healthcare professionals. At the end of this, I want all of you to have a greater understanding of pediatric cancer survivor needs after diagnosis and treatment. By the end of this, I want you to also know the patient is more than a diagnosis. They are daughters, they are sons, they could be your child as well. And that is something we need to advocate for. The day before my child was diagnosed, I wasn't a cancer patient or cancer parent either. Each year, 400,000 children and adolescents 0 to 19 years old are diagnosed with cancer worldwide. The most common types of cancer are leukemia, brain cancers, lymphomas, and solid tumors, such as neuroblastoma and Wilms tumor. Back in 1997, my parents heard for the first time, your child has cancer. Michael Marfio Jr. was diagnosed in December of 1997 with medulloblastoma. He began his treatments at Hasbro Children's Hospital and unfortunately lost his battle in April of 1998. My little brother shined to the world though, and is the reason I get to stand up here today. He taught my parents and I the importance of advocating for your child, as well as what healthcare professionals can do to help everyone around them and how the whole family is diagnosed. Just because he was the cancer patient, my parents also were patients as well as cancer parents. How much funding does pediatric cancer receive for research and medication development? It was spoken earlier this morning, and I know all of you may know this, but it is only 4%. They did talk about earlier how there's very little new treatments for pediatric cancer patients. That is something that we need to advocate for, and only us here in this room, as well as our partners across the country, can be the ones to make that change. Because every day, 43 children from 0 to 19 are diagnosed with cancer. By the end of my presentation, almost 12 children will be diagnosed, and parents will hear the words again, your child has cancer. Within every 3 minutes, a child is diagnosed. And with that diagnosis, the patients and the families begin a journey. When Michael was diagnosed, my parents did not know much about the medical field. They didn't know the newest treatments and protocols. They had to become advocates for their child as well as specialists in the field, which is overwhelming because at the first word, all you think about is, I need to protect my child. I need to do everything I can to make them survive. But then I also have a job. I have other children. How am I going to cook dinner tonight? And Christmas is 2 weeks away. And at the end of the day, they are trying to focus on and process that their child may not be able to join them on their next birthday, their next holiday, or even just to go to kindergarten. And that is when healthcare professionals need to talk to the patients, to the families, to the siblings, and see that the whole family is diagnosed, and we need to begin to treat them as a whole. And this is where the importance of multidisciplinary teams and palliative care come in, because they get to see the multiple aspects of what patients and families experience. So the doctors are writing the orders, the nurses are doing the task, but then I have my social workers, my chaplains, and then my palliative care doctors that are able to fill in the cracks, that are able to come in and go, I need this pain control regimen better because my patient is experiencing severe bone pain because they have severe bone cancer. You're not doing it right. And it's because palliative care works on symptom management. Using your multidisciplinary team gets everyone involved, and having that from the diagnosis, from the day one, has better outcomes. It helps the parents, it helps the patients, and even myself working in the adult population, they are happier. Even if it's just a chaplain coming in, sitting down and talking to them and going, hey, what are you watching on the TV? Because they are more than just that diagnosis. That is us as healthcare professionals need to remember. They have the name, date of birth, diagnosis, treatment plan. But who is that person? What do they do before their cancer diagnosis, and what can they do after? And with pediatric cancer kids, they know they have cancer, but they live every day as if they're not going to pass away. They know they're sick. I knew I was sick when I was diagnosed. My brother Michael did. And my parents never hid that fact. And that's where children and adolescents with cancer, they wish to talk about the meaning of being ill. They wish to be involved with their care teams. They want to know what's going on and to be advocates for themselves sometimes of, no, I don't want to do that now. Can I wait an hour? Giving that little bit of autonomy, even to a 5-year-old, can make such a difference in that care. I know for myself, when Michael was going through his treatment, the doctors and nurses let me listen to his heartbeat, his lungs. They taught me how to take vital signs. Now, I was 4 years old, and those wonderful nurses took the time to have me learn. They told me what my brother was going through, because every day my dad would bring me to the hospital, drop me off, say goodbye to my mom and brother. He would go to work and then pick me up to go home at night. So I was right there with him as he had surgeries, treatments, but we also got to be kids and play in the playroom and have the different wonderful volunteers come in that do activities and arts and crafts. And we get to celebrate holidays in the hospital as if we weren't sick. And that is where kids teach you so much. And I didn't realize it, obviously, when I was that young. It wasn't until I had the privilege as Miss Rhode Island to go back to Hasbro. But they tell you, yeah, I have cancer, I'm sick, but I'm okay. And their amazing strength they have. My mom also gave me the opportunity to process my feelings of what I was going through by having me color and speak about my experience with Michael in a book now put together called Mikey's Love. In this book, it goes through from the diagnosis to the day Michael passed away, what I saw through a child's eyes. And it's just very little pictures, as you can see there. It's nothing professional, but it's how she helped me cope with the fact my brother was diagnosed and that he did end up going to heaven. And I applaud her because she did have that. She was processing what her own child was going through and still had that wonderful motherly instinct to care for her other child in that way. And unfortunately, a year later, I went from big sister to cancer patient. I went in for a case of pneumonia to Hasbro Children's Hospital in the ER, and my pediatrician requested a chest x-ray. From that chest x-ray, it showed a mass behind my left lung. Most of the doctors did not believe it was cancer because a year prior, my parents just lost a child to cancer. They told him, how could you have 2 kids with cancer? Nope, definitely not cancer. We don't think it is. One surgeon, Dr. K, said, well, even if it isn't, let's take the tumor out. And I owe my life and my career to Dr. K giving me a shot and doing that surgery. She is the reason why I am standing here, because she went against what certain oncologists said, what other doctors said, spoke to my parents and said, I want to do this surgery, because even if it's benign, we got it out of her system, and then we can go from there. I was able to have my surgery in April of 1999, and it was successful. My parents did a new protocol of no chemotherapy. It was something that many thought was odd because the normal treatment, and even to this day, is you do surgery or you do chemo prior to surgery or you do it after. My parents said, no, we went through this with Michael. We know the side effects. We don't want her to end up with any more chronic problems than what she's already going to end up with. We don't want her to have the side effects of harsh chemicals in our 5-year-old daughter. They advocated for me. They're the reason I didn't have to have chemotherapy. They gave that option because they did their research. They found the new protocols. They had a surgeon that was able to advocate and support them in that. And that's when it comes in as healthcare professionals that parents may and families seem overwhelming. I'm a nurse. Trust me, we deal with very difficult families and patients at times, but they also are there to advocate for their loved ones, just as we would. And sometimes, yes, they do find a new clinical trial, and we are the ones that get to intervene and give that support and connect with those healthcare professionals in new avenues and new states and new healthcare facilities. But we have to be open-minded, because sometimes those new protocols, those new clinical trials are the reason that kids get to grow up. And I'm one of those kids. Because I was given a chance at life, I was able to go on, graduate high school, and then begin my career trying to pursue medicine. And in the process, I had the honor of becoming Miss Rhode Island. In 2013, I was crowned Miss Rhode Island in Providence, and I ended up going through 307 appearances throughout the state, speaking to thousands of children on my platform, Be Friends First, which was promoting healthy relationship education from K through 12, and a mentorship program for college students, as well as competing at the Miss America pageant, where I placed top 5 for science, technology, engineering, and math, and second runner-up for Quality of Life Award for my work with BFF. Through this process, my platform was something different than cancer, because I knew as soon as I embarked on the journey of Miss Rhode Island, the top title was going to be Cancer Survivor Wins Miss Rhode Island, which is wonderful. I am very proud to be a cancer survivor, but there's so much more to every individual that is a cancer patient or a cancer survivor. So I chose a different platform about educating kids about healthy relationships. I still advocated for cancer. I still promoted pediatric cancer awareness, but I wanted to also advocate of other interests I had. And that is something we can remember as professionals. They're more than the diagnosis. It's more than a headline, because cancer patients and cancer survivors grow up to become doctors, nurses, teachers, moms and dads, and that's really the headline. And truly, I began to learn the importance of pediatric cancer even more in their strength, where every Monday I had the opportunity to go to Rhode Children's Hospital, the 5th floor, as well as their playroom in the Tomorrow Fun Clinic. I got to talk and laugh, do arts and crafts, and of course, give them the opportunity to wear a crown, because we all love that opportunity if we get the chance. Adults do too. I have a few people in this room that wore it back in 2013. These kids showed me what I had to do with my life was not to become a physician, which was my goal at the time, but to become a nurse. After my time at Rhode Children's Hospital on Mondays, I decided to switch my major from pre-med to nursing. And that is how I went from a crown to a cap. I was fortunate enough to achieve my nursing education through St. Joe's, which I'm very sad they're shut down. They gave me the building blocks to become a wonderful nurse. And then I began to start my nursing career at Roger Williams Medical Center, which I won't get emotional, but my nursing preceptor is here that took me under her wing, right there, Meredith Sunday. She taught me how to be a nurse. She's the reason why I'm able to run a code and run a rapid response, because my first ones were with her. And she stood at the door and went, "You got this, I'm just gonna stand here." And when you are a brand new nurse, you're going, "Oh no, please just do everything." Roger Williams gave me a wonderful building blocks to my nursing career. It also started me in my first aspect of being a nurse in oncology. I had the privilege to be a bone marrow transplant nurse and to administer chemotherapy as an oncology nurse as well. And those are some of my favorite moments of my nursing career. Oncology will always have my heart. Despite being in critical care now, that is my passion, oncology has my heart, because these patients truly taught me how important being a nurse is, advocating for your patient. And for someone that got to see what the nurses did for me, what my parents did for me, I got to do that for them. I now had the opportunity to grow and learn with them, as well as this is a new trial. We get to do it. We have all the research. We now get to administer it. That was probably one of the coolest things, is Roger Williams did have clinical trials that we got to be a part of. And patients had success. And you get to see them go on to celebrate a birthday, attend their daughter's wedding, or even the simple celebrating a holiday in their room, but they made it to Christmas. Those are the moments that being a nurse makes it all worth it. And that is something that right now we are in a nursing crisis, that each of us as a nurse and anyone that has a nurse in your life, have them remember that passion to drive them every day, especially for those new grads, because it's those moments that will help you move forward. It's also going to be the building blocks that support your nursing career in your future. From Roger Williams, I did eventually move on to Rhode Island Hospital, and I am very proud to be a member of the RICU team in critical care. Mid-pandemic, before the second surge of COVID, I left my very sterile, clean environment of transplant to go in what I call the rodeo of the RICU, because it is a bit crazy, but it is so exciting. And probably I have learned so much in just the year I have been there. And I am very thankful for that. And with that correlation from critical care to oncology, palliative care is still there. Pediatrics need this palliative care. And it's with that, palliative care is the comprehensive care approach. A lot of times our oncology patients will end up in critical care environments, and nurses won't know what to do. They get nervous. I know even when I was in transplant, I shipped patients off to the ICU and they went, "What does day -1 mean? What does day +2 mean?" All those terms, because it's not their specialty. I have oncology patients that end up in the RICU that are neutropenic. There's certain precautions that we're not used to because without oncology, but a lot of the time it's that palliative care and that multidisciplinary team that comes in and goes, "Hey, this is what we have to do. I know you don't know this information, but ask for help. You have the resources, use them." And a lot of the time it comes from one healthcare professional, let it be a social worker, a physician, or a nurse. They're the ones that go, "This is what my patient needs. This is how we can coordinate care. What can we do to better further their care plan path in their journey?" And a lot of times with pediatrics, we don't have that opportunity. It's diagnosis, here's the protocol, here's the chemo, here's this, and hospitals don't have that palliative care option. It's not in every hospital. It relies back on the parents They're looking to support groups. They're looking to organizations for that help of how can I be there for my child? What are the best ways that I can advocate and support them moving forward? We shouldn't be having parents have to do the hard research. We should be having a multidisciplinary team right there at the bedside, day diagnosis or within the first 72 hours, because there are better outcomes. We are very lucky today that we have wonderful organizations in our hospitals that have social workers at the bedside. The Izzy Foundation, a part of Hasbro Children's Hospital, it's on the 5th floor. Izzy's parents unfortunately lost Izzy back in 2012. They saw a need when they were their own patients there. What can we do to improve patient care? What can we improve to help the families? And that was starting the Izzy Family Room on the 5th floor. There's a licensed social worker there with office hours. We provide meals 5 days a week for families. Because as simple as your child is undergoing treatment and you don't want to go to the cafeteria so a mom doesn't eat or a dad or a grandma, they'll bring it to you in the room. Those are things my parents didn't have back in the late 90s. And not because no one wanted to help, it's because it wasn't there yet. So we're lucky that we have organizations like the Izzy Fund that come in and here's this. We do toys for the kids at Christmas or even simple care packages, because when your child is diagnosed with cancer, especially with leukemics, and it goes same with adults, with peds, the doctor calls and says, I need you to go to the ER. You need to go right away. You got to go be admitted. The blood work's off. We got to work you up. A lot of patients think in families, oh, it's probably going to be like a day or two. It's not. It's 2 to 3 weeks for a leukemic workup. So now you have a mom that left probably her other kids at home or a dad that they're rushed to the ER. They have maybe clothes for a day or two, maybe a toothbrush if they remembered in the process. And then they're admitted to the floor and get told, you're here for the next 2 to 3 weeks probably. We got to start an aggressive chemo. They're going to have surgery next week. And they have to process that. Organizations such as the Izzy Fund go, here's a care package. Right here is your toothbrush, toothpaste, shampoo, conditioner, resources of local organizations that's going to help you. Because 6 months from now, when you need help paying for gas or parking fees, these are the people you can call and rely on. Those are things that we are improving every day, but we still can do better. We still can improve on the pediatric cancer support system for families and patients. And from that diagnosis, a lot of kids grow up, and that's where survivors need the care too. 400,000 pediatric cancer survivors, an estimated 73%, will have a chronic health condition. Studies suggest 42% of those will likely experience a severe, disabling, or life-threatening condition or death. I'm one of the cancer kids that grew up. I know I was followed by the Tomorrow Fund Clinic for many years, and then all of a sudden you turn 19, 20, and you're done, and you graduate from the PD program. And it's so exciting because you don't have to go I was like every 2 years at that point, I was in a survivorship program. But then where do you go from there? You then end up in this gray area that a lot of kids do as a young adult. I go to my primary care, but do they understand what I went through? Do they understand what side effects they have to go in? So you have to become your own healthcare advocate. These survivors now have to be specialists in the cancer they have, on top of trying to go to college and just be a young adult. We need to do better in supporting them. We need to have options for these survivors right there when we graduate them from a survivorship program. This is what you can do. This is how you can advocate. And a resource, maybe give a call or have a mentorship program that other survivors, this is what I went through. Yes, I've been cancer-free for 15 years, but now I want to start a family. Where do I go from there? Or I don't want to move to an area where there's environmental factors that I can have an influence that can trigger my cancer. Or is there a secondary cancer that can come up? Because a lot of these chemotherapies you have had or different surgeries or treatments can trigger other cancers in years to come. I know for myself, I had CAT scans, x-rays multiple times a year for many years. And it got to a point that they switched from doing CAT scans for me to x-rays when I was in my preteen ages because they were afraid I was getting too much radiation from just the testing. Now I'm older and I think, how did all that radiation affect me? That's something I had to advocate for with my healthcare providers of, hey, I know you think I'm a healthy 28-year-old, but fun fact, I had cancer. I dealt with this. What are you going to do about it? And a lot of them go, wow, you had cancer? But you look great. It's great, but I did. How can I prevent this? How can I help further my healthcare journey to better myself? And that's where us as healthcare professionals, if you see someone that had pediatric cancer on their history form, ask them about it, ask them what treatments, and research it. Because especially with primary care providers, you're their front line at that point. You're their front line that if they have a symptom that could trigger something of a cancer, you get to write that order to help them. It could be as simple as blood work or a chest x-ray. I know from my provider, she knows I'm more prone to upper respiratory infections, which it's kind of ironic. I now work in a respiratory unit during a pandemic of a respiratory virus. But she knows that. So if I go in with any sign of pneumonia, bronchitis, I get a chest x-ray right away. I get pneumonia every other year. It's very unusual for a 28-year-old, but that's something that I'm going to live with for the rest of my life because of my cancer diagnosis. And that's where 73% will have a chronic health condition. And how the importance of integrating that palliative care from the get-go can truly help families and patients in their healthcare journey. I know I keep repeating myself with it. It's so important. Like as a nurse, I see such a difference in my patients that have palliative care from day one, or it's myself or the other nurses that are like, where's palliative? Because all of a sudden they're ready for hospice, but we're just talking about palliative care. Palliative care and hospice are two completely different things, and people don't realize that. They think palliative and hospice go hand in hand, and they do not. Palliative care treats symptom management and chronic terminal illnesses, and hospice is end-of-life care. It's two separate things. We should not be talking to palliative the week before someone goes to hospice. Palliative should be involved when they're diagnosed with a chronic or terminal illness. Hospice is involved for end of life. And if we separate those two and learn that distinction, that truly will help our patient outcomes and our patient care. So as I talked about earlier, palliative care is currently used in practice in all pediatric care settings. This is false. It is not. And that is something we truly can all improve on.
The minute this dog sees something different,
Oh, I know.
his mind is.
And in the
just
words of
so-
Yeah,
Florence
he
Nightingale,
has
I hope we
very
let
short
us never
attention
consider
span.
ourselves finished nurses. We must be learning all our lives. And that is something I am so glad to see all of you here today, everyone on Zoom, that you're taking the opportunity to learn something new. Pediatric cancer is something that not everyone knows about it, but no one truly knows the importance or the support the family and patients need until you become a cancer parent, a cancer sister, or a cancer patient yourself. And that is what we all must take to heart, that we can be the change if we advocate and learn what our patients and families need. Thank you.
I think I speak for everyone here and everybody out there virtually when I say, wow. Now, Jessica's agreed that she would take questions. If anybody has a question for her, please come to the microphone. I see Todd is the first one up, so we'll start with you.
Hi, Jessica. Welcome back. I was here 8 years ago when you talked about that, and it's wonderful to see you here following your dream, one of your dreams. I'd like for you, if you could, speak a little bit more about the impact of pediatric cancer or a diagnosis on a family. And about how When there's a sick child, the sick child sort of absorbs a lot of the family's resources, financial, time, emotional. And so how we as a medical community, I'm a social worker, can do a better job in supporting the whole family.
Absolutely. So you are correct in saying that it does absorb the primary attention. So when a patient is diagnosed, that's going to be the primary focus, and it should be. The parents need to focus on what's going on with their treatment care. But then the other siblings a lot of them feel left out. They're left at home. Why is mom always with my brother? Why is mom always with sister? What did I do? Why can't I have cancer too? I have heard that from a sibling because they feel if they had cancer, they would be getting all the attention and everything there. As a healthcare team, we have to see that yes, the patient and the parents or caregivers are the primary focus, but the siblings also need attention too. And that's where resources such as social work and child development can go in and say, do you have any kids at home? What are they doing? Are they coming to see their sibling? Can we have them do a dinner in the Izzy family room? Because that has been huge for families. They're able to do a family dinner in that room. Can we watch a virtual soccer game of them and you can talk to them after the game? Doing little things like that and including the children that are outside still at school or doing activities at the home and seeing how we can support them in that way can kind of connect, as well as looking at community resources that can help families. So the Tomorrow Fund, the Izzy Fund, all those local organizations, they truly help the families. It's not just the patient. It is not just looking at how can we support them during treatment. It is, what are the siblings doing? I know the Izzy Foundation, they give scholarships to cancer siblings. That's something that organizations don't do. Usually cancer scholarships only go to cancer survivors. They give that opportunity that if you're a sibling of someone who has passed away or undergoing treatment or became a survivor, they can get a college scholarship. That's huge. That's recognizing you went through something too. You're diagnosed as a family with cancer, and we're going to support you as you move forward in that, as well as making sure they have the resources to go to their primary care or for preventative treatment, because you do want to see if one child's diagnosed, is this genetic? Is this going to be spread across the family? How can we support that young child's sister or brother to not be afraid of getting cancer as they get older? And what can we do to support them in that journey? Yes.
Hi, Jessica.
Hi.
This question speaks to sort of the psychosocial aspect of nursing and receiving care. And I just wonder if you could speak for a moment about, I think the relationship that, I'm a caregiver. My wife has had cancer for about 18 years. And I think the relationship with the healthcare professional has been clearly instrumental in our lives in prolonging and improving the quality of life that we've received. And I know there's also the issue sometime about boundaries and, you know, how much can you really become sort of a friend of somebody that you're also their treating caregiver. Could you speak a little bit about, as a child who's receiving services and also now as a nursing professional providing those services, what your perspective is on that caring aspect and the boundaries issues?
Absolutely. So I will say being a cancer patient is very different from being a cancer nurse. However, it gave me an opportunity to have empathy for my patients in a new way and also see the family as a holistic diagnosis, even if it was an adult being diagnosed. And I had 18 to 21-year-olds too that I took care of. They're young, they're kids too. They still are considered. And even though they're treated in an adult population, their siblings are still there, their parents are still very involved. And that's where the resources you have to rely on of your multidisciplinary team. I know at myself as a caregiver, those are the moments that I take a step back and go, how can I improve as a nurse? What are their key needs? I know I walk in every day for any of my patients and look at them and say, what's your goal today? What do you want to do? Obviously in the RICU, I can't do that all the time because a lot of my patients are intubated. But back in BMT days, I was able to do that with my transplant patients. And we walk in and go, hey, what do you want to do today? Are you going to do 10 laps around the unit or are you going to do 2? Or maybe it's just getting up to that chair. So it's looking at those simple little things that are big deals when you're a caregiver. Sometimes the biggest deal in the world is they finished breakfast or they were able to take all their meds before 9 a.m. And it's looking at those little features that we're able to become a supportive caregiver, but also looking if they have a caregiver such as yourself for 18 years, how can we support the caregiver? Caregiver burnout's a real thing. And that's where social work and our case management has to be involved to support the caregiver and saying, maybe we need a little respite care. Maybe you need to go to the grocery store by yourself and have someone else come and watch them. Maybe you need to take that step back and just take a walk outside. Turn your phone off, go take a walk for 20 minutes. You look at all the different aspects, and realistically, caregivers are very much forgotten. And especially with pediatric cancer patients, parents are going to give their all until they can't anymore for their kids. And that is something we need to support that parent to say, go get a cup of coffee down the hall, go get lunch in the cafeteria. They're going to be okay. I got them. And it will take a while before a parent truly trusts a nurse to be alone with their child in a hospital room. And that is something that is a bond that I am very thankful that a lot of parents trust these nurses and physicians day in and day out, but truly those bedside nurses every day to leave their child with them so they can get 20 minutes or they can go to their kid's soccer game or they can go to a work meeting really quick and try to still have somewhat of a normal life. Yes.
Hello.
Hello.
Thank you for sharing your story. It was actually really wonderful and it really did empower me.
Thank you.
I just had a quick question or more of a like asking for advice, like for new grads, especially for nursing students, like do you have any particular advice which you can give us regarding like what are the support or what can we as a new nurse can do in order to really advocate for this pediatric patient who are suffering from cancer or like even supporting the family, like what are some advice would you recommend for new nurse to really-
Absolutely. How many nursing students do I have here today? Oh, I love it. I love nursing students. So guys, let me give, guys, these are our future of nursing. And I will tell you one thing. Thank you. I get to take nurses on my unit. I work mostly every Thursday. I have Thursday off, obviously, but I get to take these nursing students. They are so motivated and also so scared at the same time. It's probably one of the best days I work is teaching these kids as like just a bedside nurse. They like, hey, Jess, you got a nurse for the day. So thank you all for being here because that's half of it is getting education. I'm sure it's required by your course to be here, but your professor has a method to their madness in requiring it because you will learn something and I hope you take something away. The biggest thing as a new grad, don't be afraid to ask questions. You don't know everything. You are never going to know everything. I don't know everything. I still ask questions and I still need help. And even the most senior nurse to the youngest nurse, that's something we can all do. And also don't be afraid if you have that gut feeling and you feel it in your soul and you'll have that nursing instinct that you're going to develop as time goes on, talk about it. Tell another nurse, hey, I don't think this looks right. Can you just come and look at it with me? What do you think of this order? Like, I don't think they should be doing this because you are that last line of defense. You are between pharmacy. Yes, they review it, but sometimes there's just a random doctor's order that doesn't sit right with you. And you can ask questions with another nurse. Go to your charge nurse. Go to your nursing resource educator that's on your new unit. All those people are going to be able to help you. Don't be embarrassed because they're there for a reason. They're there to help. And if any time which I'm very lucky, when I started nursing, I didn't have the nurses either young. I started in a very supportive Center 4 unit at Roger Williams that took me under their wing as a new grad. And I didn't experience that. I think as years go on, as you become more seasoned, that's when you may experience it of, oh, okay, I've been a nurse 30 years, you've only been 2 years. But as a new grad, I didn't. If you experience that as a new grad, brush it off, go home, call your friend, your mom, or your nursing friends are going to get you through life. Talk to them about it. Don't think you're a bad nurse just because you had a bad shift or a bad day. It's one shift, it's one day. And I have to remind myself very frequently of that sometimes, because we're all going to have those days.
Thank you.
Thank you for asking that question.
Speaking on nursing students, nurses, and patient advocacy, you spoke about hospice and a palliative consult coming in the week before hospice comes in. What's something that nurses can do to advocate for our patients for palliative further upstream?
So one of the biggest things is educating. Sometimes a lot of, especially new residents or interns, they don't necessarily know how important or what palliative care can do. So as a nurse, you can say, they are on X, Y, and Z pain meds. If we get palliative care involved, they may have a different take. Or we really can't control their nausea. If we get palliative care involved, they can help where their nausea management. So sometimes you've got to educate with, these are the symptoms they're having. Maybe we can involve these people to help. And it's usually, I found, not going to be the first time you ask for it. It's going to be 2 or 3 times, multiple nurses, until one doctor goes, yeah, palliative care should get involved. And you just constantly got to keep saying it. And you'll sound like a broken record with it. I know I do. And that's something we all have to just continue to do, and kind of use the symptoms as your building block on why they need the palliative care. And then remind them, if they're actively dying, they need hospice. They don't need palliative. I know families, sometimes we have to introduce palliative for a day or 2, and then we get hospice involved to kind of guide them into hospice, which I understand, but hospice is completely different. And just reminding physicians, hospice is end of life care. Palliative can help them months prior, years prior, especially with our cancer patients living for years. They are living with a cancer diagnosis and cancer treatments for multiple years, and with now chronic health conditions caused by those treatments or comorbidities they already had. So having that multidisciplinary palliative care team is really what's going to help that. Thank you. Yep. Thank you all so much. Thank you, Jim.
As you heard, Jessica, and as we've been presenting and going along, it may become obvious to you, or maybe on Zoom and virtually, that it takes a lot of work to get this summit in place and to do a great job with speakers and panels and presentations. And that involves a whole group of dedicated people who are on the planning committee. And some of the people come here just to volunteer. They were here at 6 a.m., some of them. And they will be out giving CEU awards at the end of this presentation. So if I could, I'd like to have the people who volunteered as the committee, who volunteer as workers for this event, please stand so we can appreciate you. Each year, the partnership gives out awards. And this year, we have 2 awards. We'll do one previous to the break and then one a little bit later. But the first award we're giving out is the Joseph DeMasi Memorial Healthcare Professional Award. It's a mouthful. Dr. DeMasi was the founder of the SCUP program. It's the Screening Colonoscopies for Uninsured Persons. He passed away of leukemia in April of 2012. But because of the work he did in the community, offering that kind of service to those people who weren't going to be able to have colonoscopies, the partnership, of which he was a member, dedicated the first award in his name. And each year we honor a special recipient. This year, our recipient is Dr. Abdul Calvino. And Dr. Calvino came to Rhode Island as a fellow in the complex surgery oncology program. Now that fellowship is open to 1 fellow a year. It's the only surgical oncology fellowship in the state that I'm aware of. Could be wrong. I'm looking at Dr. Calvino. There's another one? It's the only one. Yep. He came here and did that fellowship for 2 years. That's post-surgical residency. That's post-medical school. That's a pretty complex program. And since that time, he has become one of the faces of healthcare to the Latino Hispanic community. He's received many awards from different places for the work that he does in the community. But one of the things that we're most proud of is that he's demonstrated that sensitive, same language patient navigation improves patient compliance for critical screenings. He started that with the colonoscopies, and he's moved on from colonoscopies to colonoscopies and mammographies. And so we're getting to the community. When he started this, we used to call that disparities. Now we talk about it in a positive sense and name it equity. He's been doing it so long that we have a better way to frame it. Dr. Calvino, actually, from the time he did his fellowship, is now the program director for the Complex General Surgical Oncology Fellowship. He's also been the director since 2015 at Roger Williams of the Underserved Population Outreach and Cancer Care Education. So he does a lot of work with that. If I look at the support group facilitators for the Spanish-speaking cancer support group, and they're both here in the room, they will tell you that he is willing and able to speak to their people. Every time the partnership has asked him to speak at a quarterly meeting, he's spoken and educated us. He's also a board member of the partnership and very active in keeping us going and giving his wisdom. So it's my privilege and honor to present Dr. Calvino with the DeMacy Award.
Oh, thank you very much, Jim, for those kind words. You know, I'm honored and humble that we have been able to continue a little bit the work of Dr. DeMacy in terms of improving colorectal cancer screening and detection in our Hispanic community here in Rhode Island, which is an underserved population. But I want to take this time to actually highlight the amazing job that the partnership does and how the partnership, working in collaboration with other organizations, have allowed us to actually do these things. There is a lot of people who dedicate a lot of time, effort every week to make sure that the partnerships keeps moving forward. Diane, obviously, Jim, Joe, Megan, they work in collaboration with other groups, the Comprehensive Cancer Care Program, George and Dulcia is here, and many other people that have been working with in the Latino community. Betty Bernal, obviously always a leader and helping us to reach out to the Hispanic community so they can learn about how to prevent colorectal cancer. So I think the time that they put into creating this platform that will allow then us to try to reach and educate and create navigation programs is very important. I wanted just to take a minute to highlight and thank them for the job they're doing, which is allowing us to do what we want to do in terms of colorectal cancer. Thank you. So I'm sure this award is going to be fuel to continue. It's going to be fuel to create more programs, not only to Hispanics, but to other underserved populations here in Rhode Island. And I'm sure we're going to have a lot of doors to continue in our quest to decrease disparities or achieve equity in cancer care in Rhode Island. Thank you very much.
Now what I do best, show and tell. If you look at your program, the very bottom of the front page, not only did a lot of volunteers participate to get this program the way it is, but a lot of sponsors have helped us financially so that you could be here or that you could attend on Zoom. So we would just want to thank all of them, but just take a look, if you will, of the presenting sponsors and then our silver sponsors, and we thank them. I don't want to say this too quickly before I finish, but now it's time for a break. So there are not only some of our sponsors, but other people out there, exhibitors who have a lot of things and a lot of information for you to look at and to pick up. And we thank all of our exhibitors. If you're attending this virtually, there is a loop that's going to be going on, so you can see that on your screen. Kind of gives an idea of all of the people who, all of the presenters. So take a minute while we're on break and look at that if you're virtual. And while we're on break, if you're here in person, obviously, please take a minute and visit our exhibitors. Thank you. We'll be back in about 10 minutes.
While it's true that no home, neighborhood, or human is immune to cancer, it's also true that there's a world-class stronghold in the fight against it, right here in the Ocean State. Thanks to Yale New Haven Health's Smilo Cancer Hospital Care Center in Westerly. This seaside community of local business owners, educators, and fishermen now boasts leading-edge technologies, resources, and expertise that cancer never saw coming. Starting with renowned board-certified oncologists and nurses working as a team to provide individualized care, access to state-of-the-art radiation and surgical treatments, genetic testing, and clinical trials in partnership with Yale Cancer Center, and a comprehensive suite of services including lab work, advanced diagnostic imaging, and a 24/7 oncology pharmacy staffed by certified pharmacists. The very things that most people associate with big-name hospitals in big bustling cities are all located right here at Westerly Hospital. The way we see it, dealing with cancer is hard enough without having to uproot your life or loved ones to get treated. And with convenient local access to such exceptional care and treatment, you won't have to. The Smilo Cancer Hospital Care Center. It's world-class healthcare in your world. While it's true that no home, neighborhood, or human is immune to cancer, it's also true that there's a world-class stronghold in the fight against it, right here in the Ocean State. Thanks to Yale New Haven Health's Smilo Cancer Hospital Care Center in Westerly. This seaside community of local business owners, educators, and fishermen now boasts leading-edge technologies, resources, and expertise that cancer never saw coming. Starting with renowned board-certified oncologists and nurses working as a team to provide individualized care, access to state-of-the-art radiation and surgical treatments, genetic testing, and clinical trials in partnership with Yale Cancer Center, and a comprehensive suite of services including lab work, advanced diagnostic imaging, and a 24/7 oncology pharmacy staffed by certified pharmacists. The very things that most people associate with big-name hospitals in big bustling cities are all located right here at Westerly Hospital. The way we see it, dealing with cancer is hard enough without having to uproot your life or loved ones to get treated. And with convenient local access to such exceptional care and treatment, you won't have to. The Smilo Cancer Hospital Care Center. It's world-class healthcare in your world.
Well, welcome back. Hope you enjoyed the exhibitors during our break. I was reflecting on when we entered into the building here, it was cold on the outside, and you know that old saying that they have is when one door closes and another one opens, you're probably entering a prison. I didn't think that would work. But, you know, like most of you, I've been doing a lot of things by phone during the pandemic. And I love the phone messages that I've been getting. Two of them haven't made sense to me. The first one is, due to unusually high call volume, you may be experience a longer than normal wait time. That might have worked for the first 12 or 14 months, but help me with my English. If it's happened for over a year, is it still unusual, or wouldn't that be the usual call volume? I don't know. The other one that I listen to is, please listen carefully, as our menu has recently changed. And then they say, if you know your party's exchange, please call it. Well, if I knew my party's exchange and the menu has changed, how am I sure about who I'm actually calling with that number? I don't know. It never has made sense. It's kind of like that one I used a couple years ago with the, you know, every microwave has a popcorn setting, and every bag of popcorn you've ever opened says, do not use the popcorn setting on your microwave. But since I told that one, you'll be happy to note I recently got a bag of popcorn that said, don't leave the microwave unattended. So that's, so you can use the popcorn button now as long as you know to stop it. Now, our next speakers are faves of ours from the partnership. They've each spoken to us and presented. My favorite part about their presentations are they make data and statistics interesting and intelligible. You know, so they present some things for you and then help us to understand what it is we're looking at and how that benefits people. So our talk today by our two presenters is Pediatric, Adolescent, and Young Adult Cancer Reporting and Survivors' Long-Term Hardships. Our presenters have, as I say, both presented here many times. So they are Nancy LeBron, who will start, and then Junhee Oh. So we welcome them.
Hello and good morning to everybody here in person and everybody else that's out there in the virtual world. Hello. With this morning, what I'm going to be talking about is the Rhode Island Cancer Registry, where our data comes from, where our data goes, and Junhee is going to take over about more on the data side of how the data is used within Rhode Island
While it's
and
true
nationally.
that no home
I do not have any disclosures. So the agenda for me this morning is going to be kind of introducing you to what the Cancer Registry is, what data collection we do, and any special projects we're currently working on with a look into pediatric. So the Rhode Island Cancer Registry, this is our logo. We are the central registry here in Rhode Island. We collect information from all hospitals and freestanding radiation clinics. We also do interstate data exchange, which I'll get into further down. So the Rhode Island Cancer Registry is a data repository. We have right now in our database cancer diagnosed and or treated in Rhode Island since 1986. They're Rhode Island residents of all ages diagnosed and or treated outside of Rhode Island as well. How do we get the information? We get it from hospitals and freestanding radiation centers in Rhode Island. And we also have agreements with other states all over the United States. What information we collect is demographic information on patients, so name, date of birth, social security number, address, things like that. Tumor-specific information means where on the body the tumor is located, the histology of the tumor, and any kind of data items that go along with that, very specific for that tumor. Any kind of treatment, chemo, radiation, hormone, biological response modifiers, and also vital records. So we go to the Department of Health once a year and we look at all the vital records to look up patients who might have been deceased in Rhode Island that we don't have a cancer case on yet. And we document that information as well. So right now, we currently receive within 6 months of data diagnosis or data first contact, we receive the case into our registry. The regulations have changed to 30 to 45 days of data diagnosis or data first contact. We're currently working very hard to meet that date timeline that we're looking at. And why do we collect this information? It's to produce comprehensive epidemiological reports on cancer, much what Junhee is going to show you in a few. and to prepare and publish extensive technical and statistical reports and publications, and support public health programs and policies. So the data collection portion is putting all those pieces together. So this is a typical run through of what we look at whenever we're doing the cases here at the Central Registry. So if you're diagnosed at Hospital A, you go for blood work at a physician's office, you have a second opinion and further workup at an out-of-state hospital, you choose to have surgery at Hospital B, and then they follow up with chemotherapy at Hospital B. All of that information is eventually reported to the Rhode Island Cancer Registry from all different facilities. When we get that information, we consolidate it into one case. So there's only one incidence of cancer for that patient, for that actual tumor itself. Then, like I mentioned, we go to vital records and we take that information, we import that into the cancer registry, we make matches or we make new cases. From there, the information is then reported to the CDC through NPCR. And that's where Dr. Richardson previously noted that the cancer registry data is sent to the CDC through the NPCR and is used for data visualization through the United States cancer statistics, and that's put out every year. So some of the special projects we're currently working on is, I'm sure you all are familiar with the Caroline Price Walker Concord Childhood Cancer Act of 2008. When Dr. Walker's daughter died of neuroblastoma, I'm sorry, it's Price, Deborah Price's daughter died of neuroblastoma, and they introduced legislation in 2008 to authorize funds to raise awareness for childhood cancer and to support children who are suffering from the disease and their families. So what this act did was look to enhance, expand, and intensify pediatric research and other activities related to pediatric cancer, therapeutically applicable research to generate effects of treatment, pediatric preclinical trial testing, and pediatric clinical trials. Senator Rhode of Rhode Island sponsored the Reauthorization Act in 2013. So Rhode Island was part of the early case capture pediatric youth, pediatric and young adult cancer project that was put out. It was 5 years. We started in 2014 as a pilot enhancement study, looked at cancers ages 000 to 019, and this is now continued under the STAR Act, which again, Dr. Richardson mentioned in her presentation earlier. So previously and currently, accessibility to research and incident prevalence is 24 to 36 months post-diagnosis. So during this time frame, during the study that we did, 2014 to 2019, we were able to get any kind of childhood cancer cases between the ages of 0 to 19 into our system within 30 to 45 days. So we were able to decrease reportability timeliness. It's not sustainable right at this point, but again, like I mentioned, we are pushing forward to get that information into us sooner so it's available for more statistics. We were able to develop methods for the rapid case reporting, and we did have success during the time frame, so we know that the availability is there. However, the number of cases was not as large as we normally accession throughout the year or on a monthly basis. So it was very beneficial for us to work one-on-one with a specific hospital and get that information into us a lot quicker. So the STAR Act was a continuation of the ECC-PYAC project. Again, it was sponsored by Senator Jack Reed in 2018. It's the Survivorship, Treatment, Access, and Research Act, which is looking to do timely data collection, electronic cancer reporting, and disease research and treatment. And it's looking to maximize research through discovery and the delivery, maximize the delivery of care, the delivery of quality of life, of survivorship, and of caregiver support. So Rhode Island began participation in 2020. This time, we're not only looking for 0 to 19, but we're looking for 0 to 29. We're working very closely in conjunction with Rhode Island Cancer Registry, with Hasbro Children's Hospital, we are the Cancer Registry, and to incorporate a tool called NOAA. What that tool is going to do is going to allow pathology reports sent directly and electronically directly to the cancer registry, so that we'll get those within days of diagnosis instead of waiting around 6 months. Right now, all facility engagement is we're looking at what they call suspense reports, and those are cases that are put into their system on a monthly basis of the previous month. And we're looking for a similar outcome. We're trying to decrease that time to 30 days to make sure that that information is in our database at that time. And hopefully the rapid case ascertainment will continue in the future as we push forward. But getting those suspense monthly files is going to be extremely helpful. Okay. Oh, and that's it. So if you guys have any questions, I'll take them after Junhee gives her presentation as well. Thank you.
Good morning, everybody. Yeah, first of all, I'd like to say thanks to the planning committee for giving me and Rhode Island Department of Health Cancer Registry to give us opportunities to share the cancer surveillance reports and discuss these critical topics around pediatric, adolescent, and young cancer survivors. So my name is Junhee. I am the Rhode Island Cancer Registry Administrator and epidemiologist at the Department of Health. I'm very proud epidemiologist, one of the epidemiologists of many epidemiologists who has worked really hard during the pandemic under the amazing leadership of Dr. Alexander Scott and also our chronic disease director over there, Nancy Sutton. Yeah, I had this really very honorable privilege to hear so many people now know what epidemiologist is and also who epidemiologists and what they do. So whenever before pandemic, so when I talk, I'm an epidemiologist, I was asked, what are you doing? But now, the more people recognize epidemiologists and importance about the public health surveillance. I have great privilege. And also I have a great privilege to talk about the cancer, representing all the cancer patients and also entire Rhode Island population who are at risk of cancer. So everybody, all million population in Rhode Island have a risk, some risk. And also when I heard Jessica's presentation, I realized that behind the patient, supporting group and relatives, families, those are all affected by the cancer reporting as well. I really appreciate this morning's presentation. So Rhode Island Cancer Registry is supported by the State of Rhode Island General Fund and also the CDC MPCL funding, so including the STAR project, innovative project, and also the modernization project. We have a lot of supplemental fundings, gratefully from the CDC. But I do not have any conflict of interest to disclose. And also I have to say, my presentation today does not really reflect any official position or opinion from the CDC, our funder. In the first section, I like to focus on pediatric, adolescent, and young adult cancer. So when I say AYA, which means adolescent, young adult. So I'll go over how these cancers are classified for the cancer surveillance purpose, and epidemiologic overviews of pediatric and AYA cancer instance, and how these cancers profiles has been changed in Rhode Island over time. I tried my best to use and analyze Rhode Island specific data. However, please understand that it was not always easy and feasible to produce meaningful and stable reports working for very rare type of cancer. So pediatric cancer is one of the example. So when we try to report with many different attributes like race, ethnicity, and geographic areas, particularly for the small a number of the cases using Rhode Island data based on small population is not that, sometimes not easy. So that's why in some measures today, I have to use the comparable regional or sometimes national data that can suggest Rhode Island statistics. So and then briefly, I'll conclude with touching some long-term and late effects for pediatric cancers. Jessica also mentioned a lot of services we need and support we need for long-term effects for the cancer survivors. But I'll just briefly touch over, based on my literature review, what long-term effects and late effects were identified. So before I brief about the Rhode Island children, adolescent, and young adults cancer epidemiology, I need to explain that the types of the cancer that develop in children and young adults are very different from those in adults. So that's why we need separate and different cancer classifications and grouping for young population. So as you know, the majority of adult cancers are originated from epithelial cells. So the carcinomas are dominant cancer type among older adults. So as you may have seen our cancer report in our data page, so most of the cancer reporting is derived by the older adults, which consist of majority of the cancer in the state population. So adult cancers are usually reported by anatomic site where the cancer is primarily developed. So the breast cancer, prostate cancer, lung cancer, etc., is the way how we group and label and report the cancer and statistics. But meanwhile, the many children's cancers are originated from germ cell or embryonal cells that resemble very early stage of lifehood. So the cancer surveillance community use age-specific cancer classifications. So based on very distinct histology features in children, pediatric, and young up to young adults cancer patients. So first classification for children aged 0 to 14 years is the International Classification of Childhood Cancer, ICCC in short name, and AYA classification codes for age 15 to 39 years. So as you see, the AYA include quite a wide range of age group from 15 to 39. So in mid-2000s, the NCI, National Cancer Institute, convened a group of expertise to redefine AYA population and cancer classifications. So the reason why they did was they recognized the AYA cancer was very understudied and also is not really well addressed. So based on their expert meetings, they corrected some inconsistencies of the young adult definition. So you may also be surprised, up to 39 years is included as a young adult. So prior to this time, in mid-2000s, young adult range was up to 24 years in European countries and 29 years in US. So now, based on these new guidelines which set the limit for young adults at 39, so not only this guideline effectively expanded of the at-risk population for young adult cancer statistics, but I see a lot of kind of important policy implications in developing the cancer prevention and outreaching these patients, particularly designing supporting the cancer survivors as well. So this is very high level of table which shows what ICCC in left side, and AYA classification on the right side. So main classification, there are 12 main types under the ICCC for age pediatric cancer, age 0 to 14 years, and then again 12 different main type of the cancer for on the AYA. So in the left side, I highlighted with bright blue the most common types among children younger than 15 years, and in the right side, the bright green light highlight are the most common types among adolescent and young adults. So as you see, some of the children and young adult cancers are rarely seen in adult population, like retinoblastoma, sarcomas. Those are very rare among adult cancers. And also interesting, in the right side, under the adolescent and young adult cancer types, so the list of the cancer shows that some kind of transition of the cancer types connecting the children and older adults. So first of all, so according to the ACS, American Cancer Society's annual report in US, so 11,000 new cancer cases and 1,200 deaths in 2020 were estimated to occur among children age 0 to 14 years. So Rhode Island cancer, pediatric cancer accounts approximately 40 cases per year annually, based on our recent 5-year data, Rhode Island Cancer Registry data. And this can be converted to about 22 cases per 100,000 children. So overall, pediatric cancer reporting represent less than 1% of all Rhode Island cases report in cancer registry. So cancer types are varied by children's age. As summarized in the graph, the most common pediatric cancers are leukemia in light blue, CNS tumors, brain or central nervous system tumors in the middle, and lymphomas in the green. So as you see, leukemias in blue color are dominant in early childhood, and brain CNS tumors are in the middle, are fairly stable throughout the children's age. Oh, so that's problem. And then the lymphomas are rarely developed among children younger than 5 years. And then children's age goes up, lymphoma becomes more common among early teenagers. So checking trend of the pediatric cancer instance in Rhode Island. So a slight increase is observed from 95 to 2019. So by an average of 0.6%, a little less than 1% increase per year. So this graph shows the combined cancer rates, both boys and girls. So the trend is very similar looking at males and female children separately. So that's why I did not include separate trend line here. So when you see less than 1% of annual increase does not really sound significant. But when you accumulate all 25 years change, that would account for about almost 15% of change from 95 to recent years. So next slide confirms that Rhode Island trends are very consistent with Northeast regional results as well. So Northeast means I combined the data of all New England neighboring states, plus New York, Pennsylvania, and New Jersey. So you can also, you see Again, 1% annual increase for male and female both for pediatric cancer instances. So when Jim said the data presentation should be interesting and intelligent, right? I feel a lot of pressures. The reason why I always feel some pressure about data presentation, so data shows, but a lot of times, particularly talking about the pediatric cancer, we cannot really explain clearly why the rate goes up. So again, so even though we see clear trend nationally and regionally and Rhode Island as well, the reason behind this are not really clearly known. So some researchers says it is possibly due to environmental factors, improved diagnosis, that's why more cancers identified, or some said the better access to care for children. So with this plot, we can also tell the boys rate slightly higher than girls. So difference between boys and girls, yeah, biologic difference, and also partly because some types of the cancer occur in boys more than girls. So I'll explain more about that. So this is by type for young, the pediatric cancers, cancer type by pediatric cancer. So again, I use the Northeast regional data because when I look at only the specific type, the number is too small in Rhode Island to further assess, confirm the trend. So I continuously looked at the Northeast regional data that are available from 2001. The common cancers like brain and CNS tumors and lymphomas really drive the graph to move upward. So this explains why overall the increasing trend among pediatric cancers. Again, we have to honestly admit that children's cancer etiology is not really well known. So when you see in around early 2000s, so there's a big bump. So I believe this is, just like other researchers said, maybe because of some improvement of diagnostic and imaging of brain cancer diagnosis. However, the improvement of diagnosis does not really explain the whole picture, because even after the 2000s, early 2000s, when we shows a lot of improvement of diagnostic technology, we see consistent increase of the CNS and brain tumors. So that's why we have to wait more studies and more money to invest, studying about the reasoning behind etiology and all the epidemiologic features. So next, let's look at the AYA, adolescent and young adults cancer. In 2020 again, ACS, American Cancer Society reported 89,500 new cancer cases and 9,270 that was estimated among adolescent and young adult population in the US. The box summarized the more detailed numbers by different age groups in the US. In Rhode Island, among AYA population, about 400 cases during recent 5 years annually we received the report, which is converted to 115 cases per 100,000 individuals. So these numbers represent 5% of all Rhode Island case reporting in cancer registry. So consistent with national and regional reports, Rhode Island AYA cancer instance among females, here's a number, female and male, at the bottom. The females number is about 2.5 times higher than male AYA cancer instance. That can be explained by greater risk of the cancer diagnosis, particularly in the breast, thyroid, and melanoma among female in age 20s and 30s. But some types of cancer, I'll present more in later slides, are more frequently diagnosed among male. So taking different AYA cancer characteristics by sex in considerations, I first summarize the cancer instance of male in this chart first. So this is male age group 15 to 39 of Rhode Island trend. So the instance, cancer instance of this age group slightly increased since 1995. Again, about less than 1% on average annually increased. And the instance trend was further reviewed by age group, different age group. So the first one, 15 to 19, second column, 20 to 24, 25, 29, 30 to 34, 35 and 39. So I clearly see as age goes up, the more cancers are developed. So, and what I did was in the light blue colors, cancer instance of the time period 95 to 2006. And then this was compared with more recent 11 years, 2007 to 2018. In the, as you see in the dark blue. If the extent of changes between two periods are small, you can definitely see increases are observed all across the different age group of this population. And these patterns are very similar and very consistent with the national and regional data as well. So I further looked at so specific age group. So first of all, the male age group 15 to 19. So again, with this very narrow age group, so it is very difficult to confirm with the Rhode Island numbers. So that's why I looked at this as national cancer reporting. So the two most common cancer types of these age groups are leukemia and also the testicular germ cell tumors among males. And this is next old age group, 20 to 29-year-old male. The most frequently diagnosed cancers is gonadal, testicular germs, mostly the testicular germ cell cancers in this age group, and then followed by carcinomas. So again, when I compared two different time periods, very interesting me. So other type of the cancer did not really change much, but carcinomas has been significantly increased from 1995 to 2006 to recent 11 years. So very similar trend among age group 30 to 39. So for 30 to 39, the cancer type is getting much closer to the patterns of the older adults. So that's why the carcinoma shows appeared at the top. And also you can see significant increase of carcinomas of this young age group as well. So I was interested in then where carcinomas has been increased. So this page summarizes the carcinomas only in selected major types. So again, in blue light colors in 1905 to 2006, and then in dark colors, more recent 11 years. So more carcinomas in thyroid at the top, and kidney cancers were identified in more recent years. So next is female age group 15 to 39, adolescent and young adults. So very similarly to male, but we see a little kind of steeper increasing trend among females in Rhode Island. Again, increasing trend of AYA cancer observed all across the age group. So distinctly from male, the carcinoma is one of the common cancers among adolescent age as well. And the carcinomas is getting more dominant when in age 20s and by age 30s, carcinomas accounts for more than half of the cancer types. So similar to male, so I also looked at what kind of carcinomas. So among female in age 20 to 39, the breast cancer is the most common, followed by thyroid. But interestingly, in most recent years, thyroid diagnosis has been really spiked a lot. But good news, a little positive note is the cervical cancer in recent years has been significantly reduced as well. So this is because the pap smear, success of pap smear, and because of the cervical HPV vaccination to prevent cervical cancers, so we see more promising the cancer incidence of reducing cervical cancer in the future. So because I run out of a little time, I skip a couple of slides. So I'll talk a little briefly about the long-term and late effects in pediatric and adolescent cancer survivors. But so we have to, at the same time, even though we are talking about the cancer is real heartbreaking to children and old entire population, but we have to celebrate at the same time a lot of advancement in treatment and successes of the saving lives. So now, by now, over 80% of the pediatric and adult cancer patients survive. So the survival rate is now over 80%. However, as Dr. Richardson also mentioned this morning, and also Jessica also mentioned again, so the late effect, the health problems that develop years after treatment is really concerning. And more and more cancer survivors live, and more problems we have to really deal with. And also the chances of having late effects increase over time. So the late effects include the subsequent cancer development risk. So one of the study I found was very interesting. So this is a UK study that followed more than 200,000 of cancer patients for about 35 and longer period. So they tracked different type of the cancer, who had the breast cancer, cervical cancer, and different type of cancer, and they tracked what kind of cancer they have secondary and later and as a subsequent cancer. So, but interestingly, a lot of lung cancers appeared as a secondary subsequent cancer. So this is one of the great study that really tracked long-term time and identified the increased risk of the subsequent cancer as a really significant issue. And this is another aspect of the cancer survivors' problems, financial hardship study. So this is a US study. So the study researchers interviewed actually cancer survivors and also control group. So as you see in the black bar, a lot of AYA cancer survivors more likely skipped medications. They took less medicine. They did not filling the prescription, and also they have to change their treatment protocols because of the cost issues compared with the non-cancer patients. And I think this is also a study from the US. So this study, they checked long-term mortality of the cancer survivors. They actively looked at the death certificate. What is the cause of death for the cancer patients, cancer survivors? So unfortunately, about 6 times and six times higher risk among the cancer survivors, both pediatric and adolescent cancer survivors. But when they check, as I said, when they check the death certificate and cause of death, the cause of death was not only the subsequent cancer, but many different chronic disease, heart disease, cardiovascular disease, and or systemic disease. So, so I just took this one from the CDC website. And this morning, I think one of the audience asked Dr. Richardson about the resource. So I listed at the bottom, the resource I took from the CDC website. So I found this is a really great source that lists a lot of specific information and very detailed information by different type of conditions as a late effects. Like cardiovascular disease, hypothyroidism, reproductive complications, psychological problem, and also financial problems. And also they also listed, they also specifically describe what we can do, what interventions and what preventions ideas, and why we need more interventions and coordination to support. And some subsequent cancers, we have to do better screening and more frequent cancer screening for the cancer patient survivors. So finally, I want to wrap up talking a little bit about the limitation and challenges of the pediatric and adolescent cancer study. So as you see, so we definitely see the increasing trend for some type of the cancer for pediatric, adolescent, and young adults cancers. However, as I mentioned, the pediatric cancer are very heterogeneous in terms of cancer type. Etiology, risk factors are very cancer type specific. So leukemia has a different risk factors, which is very different from other type of sarcoma like that. And the other main issue is, as I said, the pediatric cancer, adolescent cancer is relatively very rare. So rare means not much investment to study about this kind of cancer. And then consequently, we don't really know much about the risk factors, underlying reason, and we don't really know how can prevent like that. And working with the state data, one of the smallest state in Rhode Island, smallest state in the US, working with the rare type of cancer and studying more details about who are these children, where they live, geographic distribution or race ethnicity. Even though we have better data about the race ethnicity since 2000, but we still have problems to prove some racial disparities or racial minorities. What type of cancer is more prevalent among minorities are very difficult working with the state data. The other limitations, I also wanted to I have a vision to follow the pediatric cancer survivors using our data to see what's the subsequent cancer reported in our database like that. But however, our database still about only 25-year history. So for those who have a cancer diagnosis in 1990s or 2000, they are still in age 30s and 40s. So still it's very early to collect the data. But as our cancer registry data has more history, so we'll get more information about that. The other limitation is the cancer registry do not really collect a lot of risk factor information. So like where they live, living history and occupations, and a lot of researchers studies about the pregnancy and environmental risk factors, but we don't really collect all those information. So that's why we need more collaboration with academic institute, Brown University, Roger Williams, all the hospitals who really treat patients and have some potential to collect more information. And finally, I want to mention that for those doing some kind of follow-up studies for the cancer survivors, so in our database, we don't really know how many cancer survivors continuously live in Rhode Island. So it is possible for the cancer survivors move out of state and they have another cancer diagnosed in other state. So we have, as Nancy also mentioned, that we have the data exchange with out of state, but we have a lot of limitations to working with only single state data. So nationally, I want to let you know that there's some initiative to create the early childhood cancer database that pull all the national data of the cancer, young children's cancer survivors, and then they can better monitor some subsequent cancers and other type of cancer as well. So that's a little bit good news. And I really appreciate our local cancer registry partners in hospitals. As Nancy also mentioned that, yeah, we have many different data sources and so many dedicated, hardworking cancer registrars at the hospital. So I know the cancer registry data collection is one of the hardest jobs in the world. So I have a great privilege working with them. So not only hospitals, we have radiation facilities and labs, so that we work a lot together. And also I appreciate Central Registry staff at Harry. So without their hard work, so we cannot really share any data. And also if we don't share data, we don't really know what we know and what we do not know. So I think that is the power of data. Thank you so much.
So Junhee and Nancy are willing to answer any questions that you may have.
I got one here.
Okay. Todd.
So if you can talk a little bit more, I noticed a couple of slides. The one was the survival rate, 5-year survival rate is over 80% for the pediatric and AYA population. That number is skewed though, isn't it? Because the number is far greater for pediatrics and far worse for AYA, I believe. So some of the information that I'm familiar with is that the AYA, the adolescent young adult community, their outcomes really haven't had significant improvements in the last 30 or 40 years, where we have shown great improvements for pediatrics and the adult population. I'm wondering now why some of the data seems to be combined, which is skewing those numbers. And I guess what I'm afraid of is that then the AYA population won't get that additional revenue or attention so that we can improve those outcomes. I did notice the other slide that you had there from the research that Oxford was doing, and that as a social worker, I'm curious that if there's some behavioral aspects to why the AYA community is not showing the improvements in cancer that the other communities are. If you have any information or can talk more about that, be great.
Yeah, I appreciate that. So I think that 80%, over 80% survival is for pediatric cancer. So I thank you for clarifying that. But I think that there's another separate report about the survival for the young adult population. So again, the cancer is still very relatively rare, but because they are young, they're more likely survive. However, what I learned from the literature review is the young adult cancers has relatively higher, the proportion of the cancers that attributed to genetic factors or the family history than older adults. So it's not, we cannot really prevent or we cannot really detect early for those kinds of cancer. That's one of the challenge. So the UK study, I don't think they really collected some behavior issues like screening. So I think screening really can prevent a lot of subsequent cancer development. But again, the guidelines, so I think most of the developing cancers have the screening guideline for all the adults. So very limited chances to screening. So again, the pediatric cancers supporting is not really limited, I would say. So
Kind of, I was going to ask a question about family history and how that plays into the data you collect, and if there's any predictability, I guess, from the family history that might be included in the data you collect. And the other question or comment I had was, the partnership is about prevention and early screening and detection, and really promoting that throughout the state. And, we always struggle with, well, how do we determine the impact that it's having? And how would you determine that on the pediatric population and the young adult, which now is really extending up to, it sounds like 39 from the presentation of your data. How could we use the information that you're collecting to get some barometer on the things that we're doing around the state, the screenings at the beaches and cancer screenings, skin cancer, colonoscopy, et cetera, promoting all that, women's cancer screening program. What impact is that having on the results that you're reporting?
Related with the genetic factors and the family history. So I think even though with the limited investment for the pediatric and young adult cancer research, a lot of research is now going on to identify more the gene factors, genotype of the cancers. But the challenge is like kind of leukemia has more often studied, and some rare type of the cancer, kind of hepatoblastoma, that's very rarely studied. But each type of the cancer has very specific profile of the subtyping of genes. But I read again, by the literature review, I read that there's some kind of testing or some testing for subtyping of the cancer gene types to predict who are at risk of the pediatric cancer like that. So maybe I think there was some clinical or oncologists can talk more about that, who has better ideas about the screening impact on data. So I think that's a really great idea. So that's why we have to really more actively follow the pediatric cancer and young adult cancer population using our data. So not just passively collect. Last year we had, again, kind of innovative project to work with one of hospital. And from there, we also collected the screening information. So that's how we can, for this kind of special population, who we can work with some target population or target hospital to add additional information to supplement our cancer data. So that's how we can work on that. And women's cancer screening program, do you have any comments? So again, so our state women's cancer screening program and colorectal screening program, so a lot of the focuses are by the USTS, US Preventive Service Guideline. So that is kind of our standard and our guideline. So again, with the limited resources from the federal funding, we need a lot of justifications to expand that target population to justify why we need more resources to screen outside of that guideline like that. So that's one of the challenges in our state program. I don't know if you want to add.
I just wanted to add something that as far as the cancer registry does, so I know we've spoken before, Joe, and everything. The cancer registry does not have the data items easily accessible in the registry database. However, a lot of times we do collect family history of cancer, and a lot of the cancers we see now note that a parent might have passed from a certain type of cancer. I'm going to use breast cancer because that's well known, with the BRCA gene. And I'm not sure, like, that information's texted in our database, but it's not easily accessible to do research, much like Junhee does with the data that we have in our database. So it is in there. It's just we need to dig for it and look for it. But they do look if a mom, sister, brother, aunt, somebody in the family was diagnosed at an early age, they'll test that person, and that person hopefully will catch that cancer early enough so it doesn't develop into a full-blown carcinoma. It might just be an in situ or non-invasive. I hope that helps too.
And also, I'd like to add that again, based on my literature review, about 10% to 30% of pediatric and young adult cancers can be explained with a genetic related reason. But the most of, meaning 70% to 90%, may be related with other extrinsic factors like environmental factors or some exposures in utero. When women are pregnant, some exposures, chemical exposure, radiation, or a lot of studies actually did maternal age, paternal age, old mother's age, old father's age may be related with cancer development, or body weight when child was born, overweight, or sometimes a low birth weight may be also related with some type of cancer. That's why it's so complex, and understand the risk factors are very subtype cancer specific.
Yeah, so I'll comment quickly on the women's cancer screening and colorectal cancer screening. In terms of, like Joe was saying, I think the big thing that the partnership does and that everyone in this room is really striving to do is to work on prevention and education, to make sure that, we can identify cancer early or prevent it. And altogether, I think there's a lot of intellectual capital in this room when it comes to practitioners and providers and, social workers and all these things, epidemiologists. I think an area where public health in general struggles is with its data collection on a more micro level. So in clinics and in practices, a lot of the work that we do is working with health systems to improve those systems. So we're trying to work with them on how to utilize their EHR to the best, the best of their ability. I think overall, something that's going to help the movement to prevent cancer is to get and attract more intellectual capital in this area, like of different varieties. So like computer scientists and engineers to provide better software for the stuff that we do to collect that information and to identify predictors or, things that could lead to these types of cancers. And I think providers collect all this information. It's just not reflected in charts all the time and in an extractable way. And I think that's a big limitation in the work that we do. And that's something that we try to improve with our partners.
And also, I want to add that we are working in the public health area. So I see a lot of kind of imbalance of investment, preventions versus treatments. As we recognize, the treatment has been advanced, so many different types of cancers, so we save a lot of lives, but we don't really do much of prevention. And there are so many cancers. There are only small number of the cancers, cervical, breast cancer, colorectal cancers are really has evidence-based screening, we can intervene. However, there are so many cancers that we don't even have a lung cancers. A lot of people are have lung cancer screening, even though they are eligible. So we have to do a lot more. And also a lot of ideas are risk-based interventions. If you have a family history, so you can get more intensive the care by the providers beyond the screening. And also some interesting idea was symptom-based. So not just only stick with the evidence-based screening. So some researchers propose symptom-based. Some cancers like liver cancers can be better identified by symptoms. So there's a lot of kind of studies going on.
Thank you, Nancy and Junhee, for kind of explaining all of the hard work that's going on behind the scenes. The information that we get comes from a lot of hard work. So we appreciate your hard work, and more importantly, your always willingness to present that and inform us about what's going on. So thank you very much. We have a young cancer survivor. Thomas Harrington is his name. He was going to be here to present a poem to us. Unfortunately, he's back in treatment, but he wrote this poem during his cancer experience, and we wanted you to hear it. So Jessica Marfio has agreed to come up and read this from him.
So unfortunately, Thomas couldn't be here today. He is a wonderful young man, and despite even going through treatment currently, he still advocates for pediatric cancer. I had met him a few years ago because he's one of our Izzy Fund kids, and constantly he is emailing. He does focus groups still via Zoom. He is so inspirational, and through this, he was able to express his feelings of being diagnosed, being a young man going through cancer treatment, and this allowed him to kind of process what he was going through. My parents in the other room asking the doctor for an answer. A few moments later, I am told I have cancer. I couldn't believe what I was hearing and why. 70% chance that in a few years I could die. Went from a normal preteen to a soldier on the front lines, trying to stay in the war until my pulse flatlines. Next thing I know, I am facing my doom. I had my birthday in a hospital room. Chemo, radiation, and even surgery. Stop, you're hurting me. Days go by, leaves fall of the willow, falling the hair out of my head onto the pillow. It sounds a little crazy, ridiculous, I know. Losing my hair was the hardest thing to go. The day I lost my hair is the day I lost my dignity. I lost track of the drugs they were putting into me. Despite the voices in my head telling me to give up, I keep my head high, eyes straight, chin up. Hearing the kid next door passed away still phases me, although it also happened yesterday. Children younger than me losing their lives for what? Funny, this whole thing started with a tiny pain in my gut. So the story continues, the usual biz. Went to being a soldier from being a kid. After a few years of growing up, dropped tears and throwing up, I beat the odds, I won. Although I don't take credit for anything I've done. I'm alive today because of people like you, people who were there to get me through. The doctors who helped me, the lady who cares, because she bought me a hat when I lost my hair. The people who help or even just listen, even the littlest things can make a difference. By Thomas Harrington.
No, I'm glad I had the advantage of hearing that poem a few times before this morning. Otherwise, I wouldn't be speaking to you. But thank you, Jessica. It's time for the next partnership award. It's the Community Spirit Award, and it's going to be presented by Diane Martins.
The Community Spirit Award. This inaugural award recognizes outstanding achievements in health equity, public health, and reducing the burden of cancer for all Rhode Islanders. This award was created to honor individuals who are champions for public health, confront barriers to health equity, and provide leadership to make a difference in the lives of those with cancer, their families, and their friends. The recipient of this year's award is registered nurse Donna McDonald. I'd like Donna McDonald to come forward. I have a few more things I would like to say about Donna McDonald specifically. Donna has practiced nursing for 40 years. She has cared for patients and their families affected by cancer for most of her career. Donna McDonald is not only a registered nurse, she received her baccalaureate degree in nursing from Rhode Island College. She currently holds national certification in oncology nursing and case management. Throughout her career, she has been involved in all aspects of cancer nursing, from prevention and early detection through palliative care. Currently, she is the case manager for the program in women's oncology at Women and Infants Hospital. Donna currently serves as chairperson of the Patient and Family Advisor Committee. She volunteers with the Rhode Island and Southeastern Massachusetts chapters of the Oncology Nursing Society, as well as with our own partnership to reduce cancer in Rhode Island. She most recently also served on our ovarian cancer task force with the partnership. Donna has been described as a resourceful patient advocate. She brings a sensitivity to her work with patients receiving treatment and palliative care. Donna is well respected by her peers, and she serves as their role model. Donna goes well beyond her responsibilities as case manager, including advocating and coordinating and helping patients to navigate this cancer world. As one colleague said most recently, she's absolutely brilliant. Donna, it is with great pleasure that we honor you as this year's recipient of the Community Spirit Award. Thank you.
So thank you very much. This is an honor. It's great to work with great people, brilliant minds. I just want to draw your attention, if you turn to the Hospital Association book in your packet and take a look at page 7, you'll see the great work that the partnership has done over the past year. And one area I was involved with was the Ovarian Cancer Task Force, raising awareness of ovarian cancer in our state, and also educating all levels of providers in earlier detection, rapid detection, so our patients can get to treatment sooner. I dedicate this award to my colleagues, my coworkers, for all their hard work and their resilience out on the front lines taking care of patients along with me. Thank you.
Thank you so much.
It's time for our next break. And I know those are the words you've been waiting to hear from me most of all. We do have snacks out in the hall to kind of give us more energy. Unless you're attending virtually, then it's up to you to go to the refrigerator and see what you can find. But we do have snacks, and we'll be back in a short while. All right, thank you.
Oh, you don't have a microphone now.
This isn't that?
Oh, yeah. Put it down.
Well, we're back again. So one of the things that we've discovered is that whenever we do a panel, it's always very well received. A couple of thoughts. I know my humor hasn't gone over as well this year as usual, but it is what it is. So why don't I tell a story? About 100 years ago, there was a physician by the name of Sir William Osler. And he's famous for his statement, the secret of caring for the patient is caring for the patient, meaning offering care to the patient and, offering your kindness and compassion to the patient. But some of the things that were new during that time, 100 years ago, he went to Johns Hopkins in Baltimore, and their center was a dome with two wings that extended out from it. Looks like Diane knows this story, maybe? Okay. What's that? Okay, so while he was there, the nurses would put the patients on the bottom floor of the dome. And then Dr. Osler would come in and he would see his patients. And he would go around the circle. Now, the nurses said, Dr. Osler is rounding. That's where rounding comes from. Nowadays, we round down long corridors for some places We round in some places with a computer stand, and everybody doesn't move and everybody's right there, but they're rounding. And that was the bottom floor. Dr. Osler also let his postgraduate students, after they had finished their medical degrees and were training further, stay in the top floors of the dome. And the nurses called them residents. Now we use that term indiscriminately. You do a residency and you are a resident. You don't live at the hospital, well, you almost live at the hospital, but you know, you have a place to live someplace outside of the hospital. Now, why do I share rounding and residency? Well, that's because 100 years ago, they were brand new terms and nurses and medical staff coined them. Today, we have the same situation that we call palliative care. We kind of know what it is, but we're still trying to get the message out. What is palliative care? We thank Jessica for explaining the difference between palliative care, hospice, but to hope that those of us who recognize the importance of palliative care will demonstrate it here and spread the word so that someday in 10 years or 15 years, everybody will know palliative care as well as they know what residents are and as well as they know what rounding is. So our last panel is going to be entitled Palliative Care, Optimizing Quality of Life Across the Lifespan. It's going to be moderated by Susan DeSanto Medea. And Susan is the endowed chair for palliative care at Rhode Island, at URI School of Nursing. And so we have an expert panel covering all of the disciplines that are needed to be involved in palliative care. Well, 4 of the disciplines needed to be involved in palliative care. And we're going to let Susan step up and introduce her panel.
Great. Thank you, Jim. As Jim said, I'm Susan DeSanto Medea, and I am a nurse, an advanced practice nurse, and now working at the University of Rhode Island in the College of Nursing. Thrilled to be here today. I'm happy to see all of your faces in person, and I'm certainly happy to have the people virtually who could not attend in person this year, and hopefully next year we'll all be in person. So I'm looking forward to that. I'm going to introduce my esteemed panel. I will start at my right. And that would be Wilson Villamar. He's a Master of Divinity and board certified chaplain. He's a palliative care chaplain at the Roger Williams Medical Center. Next to him is Dr. Angela Anderson, who's also a fellow in the American Academy of Pediatrics. She is director of the Pediatric Pain, Palliative Care, and Integrative Medicine at Hasbro Children's Hospital and is also an associate professor at the Warren Albert School of Medicine and Brown University. And next to me is Laura Moynihan, sorry about that, who has a master's in social work. She's a licensed clinical social worker, and she is also certified as an oncology social worker, and she works at Hasbro's Children's Hospital as well. So I'm thrilled that they could be here with us. Before I get started, and I thank Jessica for talking a little bit about palliative care, but I'm going to reiterate a few key points that I would love for you all to take home today. So certainly when I think about palliative care, I think about living with a serious illness, and I put the emphasis on living. So today we're really talking about optimizing the quality of life across the lifespan. And I say across the lifespan because it's for anyone, children, adults, anyone living with a serious illness. It certainly is a philosophy and approach to care, and I do think these principles are universal. They certainly are for people living with a serious illness, but they can be applied to any person. It's person-focused, family-oriented care that optimizes the quality of life for a child or adult living with a serious illness. And as was talked about this morning, it also is about the family. So one thing I love about palliative care, it's the family is the unit of care. What we do in palliative care is we anticipate, prevent, and treat suffering. It is provided by an interdisciplinary team, and as you can see, we have representatives from all that interdisciplinary team. There are also other members. That would be the child life specialist, the pharmacist, occupational therapy, physical therapy, and nutritionists. So it goes well beyond just the few of us that are here today. It comprehensively addresses and responds to the physical, emotional, social, and spiritual needs of the child or adult and the family throughout the illness continuum. So just not at end of life. There is still a misconception that palliative care is hospice care. Palliative care is really the umbrella, and hospice is a part of palliative care. Hospice, as was discussed by Jessica, is for someone who has a prognosis of less than 6 months to live. Certainly, we don't know that will always be the case. I will also put in a plug for hospice, however. We are not getting it started early enough. Really, when we think the person is getting towards the end of life, it really should be initiated. But in the meantime, we do have palliative care. And that, as you'll see on the next slide, is an extra layer of support. So it does not replace your primary care physician. It doesn't replace your oncologist. It's another added layer of team to help support the person and family throughout this illness. Appropriate at any stage of the illness, earlier the better, really should be started on a diagnosis and then continue throughout the trajectory. And we have a lot of survivors who continue to receive palliative care services. Can be provided with curative treatment and life-sustaining treatment, or as the main focus of care. Includes developing a plan of care, establishing goals of care. And I think these two are really important because it takes getting to know the person and really knowing the person as an individual. As Jessica said this morning, they're not a disease. They are a person living with a serious illness, and the disease does not take that away from them. So really, my favorite question to ask is, what's important to you? And knowing that and getting to know the person. Also helps with symptom management and also bereavement support. I say bereavement support again early in the disease trajectory because when you're diagnosed, you are suffering a loss. You are going through grief. So bereavement does not start after the death. It starts throughout an illness trajectory. So the goals of palliative care, optimize quality of life. I can't say that enough. To me, that's what it's all about. I too was a nurse who started in the ICU, and I learned very early on that quality of life goes beyond the physical distress of the person to the emotional, spiritual, and social. And now even the financial. Assist with decision-making. What's important to them again? Making sure that what we're doing aligns with their goals and what they want, their preferences, their beliefs. And it also provides a great opportunity for personal growth. Legacy making, the poem that was told today, just growing as an individual, whether you're a child or an adult. And then the last slide I'll leave up during the panel discussion is just some of the key concepts. Again, you've heard these from me multiple times now, but it really does affirm life. It puts value on the life that you're living. Promotes quality of life, treats the person as an individual of who they really are, and supports the family throughout this trajectory, and if there is a case of death. The one thing I will just reiterate, very different than hospice care. Same principles, but hospice care is at end of life. Palliative care is throughout life. I also just want to mention one thing that I omitted at the beginning of this. This is National Hospice and Palliative Care Month. So I am thrilled to be here, thrilled to be leading this panel, and hope you all celebrate this month with us. So thank you, and I will turn it over to questioning our panel. The other thing I wanted to tell you, I'm asking some questions now. I want anyone in the audience to ask questions, so we'll leave time for that. And I do want the people that are virtual to put questions into the chat. We have people ready to answer, get to the microphone to voice your questions. So I will now sit down and may pop up at some point. So I'm going to start with Dr. Anderson. So Dr. Anderson, can you tell us a little bit about your role as director of the Palliative Care Center and Pediatric Pain and Integrative Medicine. And then in the second part, can you talk a little bit more specifically about your role as a palliative care physician?
Sure. Hi. Good to see you all. We'll almost see most of you all anyway. Our team at Hasbro, we've actually called ourselves the CHIPS team. And the reason why we call ourselves the CHIPS team, it's CH is for children, I is for integrative, P is for pain, and S is for supportive care. And we chose to change our name because the word palliative care is such a scary word. And people don't know what it means. And then if they look up what it means, then they get even more scared. And then they just think you want to come talk about death, or they think that people are giving up, or blah, blah, blah. And then we realize, once they meet us, we're probably some of the happiest people in the hospital. We're fun. We're the people who are running around throwing, having kids throw water balloons and, and doing stuff we really shouldn't be doing, but don't tell anybody. And we don't want people to be afraid of us, because in all honesty, the overwhelming majority of the things that we talk about are things that are fun. That's our job, is to figure out a way, if you can't walk, if you can't move, if you can't do the stuff that you used to do, well, how do we figure out a way for you to still be you, for you to still be all of you, for you to actually truly still have fun? If you've got a symptom that's making your life so that you can't do the stuff you want to do, can we address those symptoms so that you can? And can we address those symptoms? People say, oh, hospice, palliative care, they just give you a bunch of morphine and you go to sleep. We will do anything we can possibly do to have a kid be awake and playing. Sleep is not quality. Sleep is not palliative care. So there's a lot more than just morphine that you can use to help a kid live their life. And if you help a kid live their life, that's how you help the family live their life as well. I don't have the foggiest idea if I answered what your question was. I just started talking.
More about your role as a palliative care physician.
So I do that.
You did that?
I do those things.
Okay.
We do, what do we do? I think perhaps the role is different than people may think. So for instance, we had one mom whose baby was born with a heart issue, and they had hoped that the baby would get to surgery, but it became very clear after about 6 to 8 months, that the baby wasn't going to get there. So that meant that the baby was actually never going to be able to go home because she was on a ventilator. And the bottom line is her heart, if she came off of the medications to keep her heart going, she would die immediately. So when mom just mentioned one day, I wish I could just get her feet in a swimming pool. And I'm like, that's all you want? We can get her feet in a swimming pool. So we got a blow up pool and a blow up palm tree and a bikini, for the little 2-piece bikini and a 1-piece baby, but we got a little bikini and some sunshades and a lei, and we got some music, and she got her feet in a pool. But that's what palliative care is. I've got some kids who are going to outlive me. I think. But I don't know, that's my vision of palliative care. You get to know them so that when things really are hard, they feel that you know them, and that you do care about them, and that you want what they want, which is for their kid to live as long as possible, but as long of a quality life as possible. And you're willing to not run away. Anyway, I'll stop yapping because I can talk all day.
No, that was great. And I think you just reiterated some of the points of getting to know the person, who they are as an individual, whether they're a child or an adult, and then doing the things that are most important to them. So things that may be everyday occurrences for us certainly have more meaning when we're helping them achieve those. And it's all about that quality of life and living life to the fullest. I have a saying, we can't cure everyone, but we can make a difference. And so I think if we can make a difference, we're doing as much as we possibly can. So thank you. So I will turn to Laura and ask her to describe her role as a social worker in oncology and palliative care.
So I think my role overlaps a lot in terms of what I'm trying to do, as what Angie just described. I think that I view my role as really trying to get to know the patient and family on a deeper level and truly understand who they are and kind of what drives them, what drives their behaviors, what drives what they're interested in, kind of what makes things fun for them and what is quality for them. I think two of the phrases that we use a lot are kind of just bearing witness to what people are going through and like walking with them through it, not running ahead, not pushing them from behind, but kind of walking alongside of them through what they're going through. And then very pragmatically, I think my role, I do a lot of kind of therapeutic work with patients and families to kind of just work through everything that they're experiencing and their illness and their treatment. And do a lot of advocating as well on the team. And I think most of that is behind the scenes and just kind of working with the interdisciplinary team members to say, this is what the patient is saying, this is what the family is saying. I think we really need to kind of have a meeting about this or kind of help frame it this way to kind of get the family to feel supported by us. So I think those are kind of the big two umbrella things about my role.
Thank you. And I think the resources that you provide and the support you provide is integral to a family as they're going through these experiences. So thank you. And Wilson, I would ask you to talk about your role as a palliative care chaplain.
Thank you. Indeed, it is a privilege to be here. I started on this table, moved to that table to be here today. I started as a chaplain, professional chaplain at Women and Infant Hospital, and I was facing a lot of cancer for women and deaths of babies before and after neonatal stillbirths, and that was difficult at that time. Then I moved to hospice, and I was in hospice doing chaplaincy hospice for 8 years, and now I am, as that table says, I am the new Jim. I am the chaplain at Royal William Medical Hospital. And in that hospital, I have to be the chaplain consultant for the palliative care service that the hospital offers. So I have to be a chaplain to people who are with serious illnesses. And the thing is, I think, Jim, people are talking about palliative care. I think we are advancing palliative care through research, and we need to do more of that to be able to explain it, to offer it for people to take it. The same thing that we need to be able to do more research to advance spiritual care in any of these stages through the life of people. So what I do is I introduce myself to people and say, hey, I'm the chaplain. And some people say, well, it is wonderful to see you. And some people say, like, what the heck do I need a chaplain for? And that is the most difficult question, right? To explore what is meaningful to you, to explore what gives you meaning, what gives you hope, to explore what is getting you through this process, to see what will help you emotionally or spiritually in this process, and do I need to contact anyone? And just finally, one of my teachers in seminary used to say, don't just be there, do something. Don't just do something, be there. And I think sometimes we all kind of, oh, I need to do this, but I don't have time to be here. I want to be there, but I don't know what to do. And I think we have to integrate that. I think that I'm still learning how to do that for a lot of people in the hospital.
Thank you. Thank you. So I think just what you said, being present and being with that person, and I know Dr. Anderson will be talking a little bit about that in a little bit. But I'm going to turn to her now to talk about how she integrates listening into her practice.
It's almost the same, I don't know, it's actually not necessarily the same thing, but it's pretty doggone close to the being. There was that, I'm not big on talking about statistics. However, somebody did a study, I don't know who, and I don't remember when, but the bottom line is the study was looking at physicians and how they were rated in terms of empathy and caring, and how they were rated just overall. Is it a good doc or maybe not such a great doc? And the docs that got the best ratings were the ones who spoke the least. The ones who spoke, not the ones who were like, well, let me tell you what to do. Families have an inner wisdom and an inner knowledge that we don't know because we're not them. So I view our role more as the helping them find their own inner wisdom. It's more asking questions and then simply listening for the answers. And I find that that is way more helpful than the let me tell you what to do. We're good at telling people what to do because we're bossy. And you know, and you learn all this medical stuff, and so you talk the medical stuff because that's what you know. But when you talk the medical stuff, maybe that's not what it's important right now. And when you simply listen, you actually are a better doc, a better helper, a better healer, because this isn't about fixing. You know, if you're talking palliative care, there may not be a lot of fixing, but there can still be some healing. You know, I've seen people grow more than they've ever grown before. I've seen kids be more grateful than they've ever been before. I've seen families be more beautiful than they've ever been before in the most difficult situations of their lives. But we don't always have to have the answer. You know, you feel like you're supposed to do. This is really more about just shutting up and listening, I think. Anyway, I don't know.
I definitely agree. And I think it is about that listening and letting them come up with the answers sometimes, not our answers of what's most appropriate for them.
They always come up with they always come up with something better than I've ever said. I was like, that is a way better answer than anything I was thinking. Yeah.
And Laura, I will ask you, a lot of people will say that children are mini adults, and in many aspects, the principles of palliative care transfer over to them because, as I said, to me, they are universal principles that should be incorporated in everyone's life and in their care from a healthcare system. But can you tell me how psychosocial intervention should be tailored to the child as opposed to some of the things that we're doing for adults?
Yeah, I think, like you said, Susan, I think a lot of the foundational values of palliative care are the same across the lifespan. We're always focused on listening and being present. I always really like to say, like, listen with more than just your ears. Like, what are their actions telling you? What is their body language telling you? What are their facial expressions telling you? And that is something that you apply across the entire lifespan. But children are not many adults and have their own very unique needs. Younger children, for example, they really need to play. They need to have routine. They need to feel safe. They need to feel secure. Kind of some of those basic things that everyone needs. But play from a developmental standpoint is imperative for kids. And making sure they're having fun, no matter what they're going through, is one of the biggest interventions we can provide. And the kids also talk through play. We do a lot of playing of games with our kids, because a solid game of Uno will get any child to spill everything they're thinking. So making sure that you're just kind of being present with them and like meeting their just normal childhood developmental needs is important. And then adolescents and young adults are completely different. They are my favorite group by far. And I think there's so many needs that they have that they really need to feel independent. They really need to feel like they have autonomy. A lot of our kind of that like 18 to 21 age group really like grew up their whole lives waiting to get to be this age and to do things on their own and to be away from their parents. And then they get sick, and then it's kind of like sliding backwards in terms of feeling like they need help from people. They're dependent on their parents. They need parents with them for appointments and for managing their medications. And that's kind of a really unique type of psychological intervention that needs to happen in terms of like what you can do to help them regain independence and feel like they have autonomy. A lot of that, we joke a lot that, you know, a lot of that looks like maybe the medical team actually supporting the young adults a little bit more than they typically would, because it helps the young adults feel like they're doing something like independently, when in reality, the help is just not coming from their parents. It's coming from more support from the medical team. And I think that's really important because they feel like they have control over it, and they do have control over it. So those kind of interventions are really important. And then also just helping them, like Wilson said before, we do a lot of work around kind of figuring out what kind of sense people are making of what they're going through and what their purpose is. Because a lot of times when you are a young adult who's supposed to be starting work after high school or going to college, and then all of that gets taken away from you, you can kind of be left wondering, like, what is my identity now? Like, what sense of self do I have? So kind of helping them work through those kind of really difficult questions is a little bit of something that's unique to the adolescent young adult population.
Thank you. And I'll follow that up with Wilson of asking Wilson to describe a little bit about the meaning of spirituality and living with serious illness.
Yeah, well, you know, when people go to the hospital, when people are sick, it's not just the physical, it is also the emotional, and it's also the spiritual, the transcendental. You know, I have yesterday a patient who said to me, last week I had hope and I was praying. Today I feel abandoned. You know, a 97-year-old yesterday told me, nothing is pleasant anymore. I don't want to depend on my daughter. And I want to be free, you know, the same kind of autonomy that they want when they're teenagers, they want when they're 97. And it's so hard because you have to negotiate how much, how little are you involved, how do you make the person comfortable? And some people don't know because they've never been there. You know, I always hear people saying, I've never been sick. You know, well, you've never been 57 and had cancer. Oh, so that's why yeah, I don't say that, of course, right? But yeah, people, it's hard for them to catch up with what is going on to them. And sometimes hard for them to know what is it that they need spiritually or how their spirituality is being affected. We just see probably some signs. They are hopeless, they are sad, they don't know where to turn to, nothing gives them joy. And so, you know, sometimes they feel disconnected, especially now with COVID. Not many people can visit them in the hospital. Or if they come one at a time, and it's so hard to let one go, to have another one come in. So there is, you know, spirituality is also my relationship to myself, to others, to the sacred, to nature. And many times when people are seriously ill, they don't have that access. If they're in the hospital, they don't have access to nature. If they have a respiratory problem, they may not have access to the nature because they cannot breathe. So there's so many losses. And that is where spirituality comes to see, well, what can we do with the losses? How do we care for you as you go through this process?
Great, thank you. And I think you had said this earlier a little bit. I mean, spirituality is certainly something different than religiosity. And I think just exploring that with the person and really trying to find out their purpose and meaning and their attachment to a higher power, whatever that may be. It could be nature, it could be something else, but really it's about getting to know their purpose and meaning and helping them refine that sometimes. So thank you. I will go to Dr. Anderson, and you had talked a little bit about, can you describe the power of presence and your presence when you're talking with children and adolescents and young adults and their families?
I think about presence in a couple of ways. One is we have a team dog named Nemo, who doesn't like the water, but he's a really cool dog. And if you think about it, if anybody has a dog, they have a dog, and your dog just kind of knows when you're having a bad day. Like they just kind of get it, and then they come and they just hang out with you. And somehow that's healing or helpful. That's presence. Like they're there for you silently. They're just willing to hang out. They're not telling you what to do. They're not telling you how you should fix. They're not telling you what medicine to take. They're just kind of hanging out. And so I think presence comes from, number one, I got to do me. And that was actually one of my hardest lessons ever, because I'm not so good at me, because I feel like I'm supposed to be doing for others. But it was a really hard lesson to learn that I had to do me, because when I go into a room with all of me, you know, and if I've had one of those days, I actually have to stop before I go in a room and just come into me. Like, where is my energy? And if my energy is someplace where perhaps it's not very helpful, I will actually spend some time doing me. Because people feel that energy. I'm telling you, they feel that energy. They feel your sad energy. They feel your anxious energy. They feel your fear energy. And it's okay if you have the fear. It's okay. They have fear too. But whatever you can do to kind of be like okay with your fear, but bring in your compassionate energy and bring in all of your compassionate energy. And if you're all beat up, it's really hard to go in with your compassionate energy. So it's okay, I think it's mandatory to fill up so that you can go in and just be. One of my best interactions was with a little guy who I knew when I used to work in the emergency department, and I wasn't doing palliative care at the time. But he was in the hospital all the time, like all the time. And he happened to be in there by himself. And I went to just go see him from the ED, and he's sitting on his bed and he's sitting by himself. He's probably like, I think he's like 10 at the time. He'd had cancer since he was 2. And he's sitting on his bed and he just looks like he's having a tough day. And so I just went in and I just sat next to him. I was like, you want to talk? He's like, I said, okay. Is it okay if I sit? Okay. And we probably sat for maybe 15 minutes, which doesn't sound like a long time, but it's a really long time to say absolutely nothing. Absolutely nothing. And I said nothing because I didn't feel like I had to say anything. And I also didn't know what to say. In all honesty, I mean, being honest, I'm like, I don't know. And I have to say, I was kind of feeling like, am I supposed to be saying something? And then I said, you know what? Maybe I gave myself permission to just hang out. And at the end of whatever time that was, because I was actually supposed to be working in the emergency department, I was like, you know, dude, I gotta go, but thanks for letting me hang out. I didn't say anything. I said, can I come back another time? He's like, yeah. And I go to leave, and as I'm walking out the door, he's like, Dr. A? And I was like, yeah, buddy. And he just goes, thank you. I had said nothing. I had said absolutely nothing. So anyway, I think that there's power in it. It's unpalpable power. But when we're all feeling like, oh, I should be doing, or I don't know what to say, or I'm not enough, when you're feeling like you're not enough and you leave because you're feeling like you're not enough, perhaps there was an opportunity to just feel what they're feeling. You know, you think you feel anxious or scared, or you don't know what to do. They're probably feeling the same thing. So if you have the willingness to kind of sort of be with, I think that's palliative care.
Right. And I think that shows the power of having a connection, whether it's verbal or nonverbal, and just your mere presence is showing that you care. So thank you. And Laura, if you can tell me about how we as healthcare providers or as people can help to integrate psychosocial interventions as we interact with children and adolescents and young adults and adults living with serious illness.
Yeah, I'm going to reiterate what has now been said about 17 times, but being present and listening, I think, are the biggest things. Just showing up. It's a kind of long story that I will make very short, but we had a patient who did not talk to anyone for a very long time, and would just come in and have his hood on and stare ahead and answer questions, and he knew how to answer everything appropriately, just in as few words as possible. And I would just go in there every single time he was there and just sit there in complete silence for 10 minutes And we played that game for about a year and a half. And then eventually one day he just started talking and did not stop talking for 3 hours or so. And it was like he was saying everything that he hadn't said in years. And Dr. Anderson walked in about halfway through and sat for the second hour and a half part of it.
We didn't say a lot either.
No, we said nothing. And I think that moment for that patient, he just said all of the things, and then at the end said something like, well, if you two don't think I'm too weird and you listen to everything I was saying, then I guess I'll keep talking. And then from then until the day he died, he was very open and talked with everyone. So I think just like being able to pay attention to what people need, even if you can't articulate what that is, or if they can't articulate what that is. I think sometimes being able to just kind of take in what is in front of you and be able to say, I think this person just needs me to keep showing up, or, you know, this person isn't asking for help with this, but it seems like, you know, they're really struggling to, you know, spend time with their friends, or aren't sure how to explain this to their parents or something like that. So being able to kind of sense what people need and reflect that to them and say, you know, is this something you want help with? I also think just being able to kind of give people as much of a sense of control as they possibly can have when they're going through a course of illness. Working with them, like I said, with like the adolescents and young adults, and really anyone, even 97-year-olds, being able to say, you know, what in this situation do you have control over, and how can we make you feel like you have even more control over other things? And then just like being able to really decide again what quality of life means for people. Talk to them, see what's important to them, and be able to kind of make that work. I think that's what palliative care is not only assessing, but then taking the next step to make it happen. And I think that's something we can all do in our interactions, like as healthcare members, and then also just as humans in terms of our interaction with other people.
Thank you. And I think once again, you brought up just being present again. It sounds redundant, but I think just showing up, as you said, of being there for the person, even when they don't want to talk, so they don't feel abandoned. I think that control, when they're losing control over everything else in their life, having some sense of control can be really helpful for them. And then the other thing I would just thought about as we were all talking about listening, and this is an old expression, but we have 2 ears and 1 mouth for a reason. And so it's talking about why we should listen much more than we speak, even though I'm speaking a lot. Anyway, I will turn to Wilson right now to ask him how we can integrate spirituality into our everyday interactions with people living with serious illness.
I think that some people don't think about spirituality or are afraid of talking about spirituality because spirituality is very private. You know, I hang out with my chickens, and that is probably when I feel more alive in the morning, when I'm feeding my chickens and my dogs are with the chickens. I tell the story to the patient comes and like, what, you have chickens here in Rhode Island? Yes. Oh, I used to have this. You know, and the person who is sad suddenly start telling stories about her animals when she was in her country. So there is this understanding that sometimes the spirituality and the spiritual life is private, and it is. But when you are sick, probably you need to exteriorize that need. Yes, I have a spirituality, and this is how I need to care for it. I meditate. I need my pastor. I need my friend. I need my book. I need this time. I need this silence. I need this ritual. And I think that people just have different ways to express their spirituality. I need to be alone. Leave me alone. I always tell people, you know, you are so lucky that I'm the only person that you can kick out of the room. This is like, what? I can do that? Yes, I don't have to give you medicine. I don't have to tell you this thing. You can kick me out. He's like, wow, I never thought that. I was afraid. Kick me out, okay? He's like, okay, get out. But come back tomorrow, okay? I come back. So, just giving people this empowerment to know that they can be themselves in the hospital and express who they are with their beliefs, with their values, with their culture, with their language, it's okay because you're going through this and we're going to help you through this too. So we want to help you. Let us know how we can help you. What is your spirituality? And some people really have different needs, different losses. The loss of hope, I already said that, the loss of sense of dignity. Some people are still dealing with the past, addictions, abuses, anything. So, I think there is a lot of opportunities to explore spirituality when you are sick, and also when you're healthy.
And I think because I am palliative care, I will say I think palliative care tries to fill some of those gaps and help people maintain dignity in serious illness, and certainly about learning their values, beliefs, and preferences, and then helping to support them through that, both as a person living with the disease, but also as a family member. Certainly a disease happens to the individual, but it certainly affects the entire family. Not to the same extent, I would never take that away from a person living with a serious illness, but it certainly transcends the entire family system. So I'm now going to thank our panelists and open it up to questions from our audience. If you do go up to the microphone, you can remove your mask because there are shields on the microphone if you feel comfortable. Of course, that's just so we can hear you a little bit better. And as I said, there may be some chat questions coming in, which we're hoping from our virtual audience. The other thing in palliative care is there's no right or wrong answer. So I always remind people that there's no right or wrong question. Everything's a gray area. So please, great.
My question is, in the inpatient setting in a hospital stay, a patient stay, things can kind of move so fast between going to tests or different consults coming in. And there's plenty of services that can be utilized to help a patient, physical therapy, palliative care, occupational therapy. And sometimes the stay is moving so fast that utilizing those consults or resources are missed because there's so much going on. And then before you know it, the patient is discharged. My question is, what are some tips that a caregiver or patient advocate or a family member can have to make sure that those resources are utilized and they aren't missed during their hospital stay?
I can say something. I can always say something. I will say this, I will say we don't have it, but perhaps we should, because your question is a very good one. But there are some places, particularly larger institutions, which will have a list of criteria, so to speak. If there's a patient who has been in the hospital for X number of days, this patient has X number of consults already called. If this patient has I don't know, something, but different criteria that would trigger a palliative care consult, then that can be really, really helpful. Our team in our hospital is so small and everybody knows us, maybe because we're so loud, I don't know, but everybody knows us. So generally, either the nurse will hit us or another doc will hit us, or we'll find actually patients who are in the hospital a lot talk to each other. And then they'll tell, the other family, hey, go ask for those short people who talk a lot, who run around and talk too fast, talk to them, and they'll find us. But there are places that actually do have criteria.
Some institutions do have triggers, as Dr. Anderson just said, but I think there's still a lot of pushback sometimes about palliative care, even by healthcare professionals, where they'll say, oh, they're not ready for palliative care yet, because they still equate it with hospice care. So I think being proactive, certainly providing people with information, talking about palliative care upon diagnosis before they ever even get into the hospital setting. I like to think of it as a dose effect. They may not need every one of us from the very admission, but they're connected, or from their diagnosis, but they're connected with the services, and then they can pick and choose what services they need at what time. I also think there's a great need for expanding palliative care more into the community. and into outpatient settings. And we now have primary palliative care, which we should all be talking about palliative care, and then using the specialists when symptoms are out of control or we can't handle it. But I think certainly trying to get this out into the community, talking about it, saying what the benefits can be, and that it's not end of life care. It's really quality of life care.
I would also just add quickly that I think if you find that you yourself or a family member is in the hospital, I think it's okay to kind of do what kind of we have been describing that we do as providers and take a step back and say, what do I need right now? To take a step back and say, what do I need right now? What does my family member need right now? And then maybe ask for that consult while you're in the hospital. You know, like we're really struggling emotionally. Can we have a social work consult? Or, you know, we've been really struggling with our spirituality. Can we talk to a chaplain? So kind of do a check-in with yourself and say, you know, what is it that I feel like I need right now? And what would help me feel a little bit like my heart is more full coming out of the hospital?
I'll do one disclaimer. When I say upon diagnosis, it may not be that day exactly because they're just getting hit with a diagnosis, but knowing that those services are available to them throughout their illness trajectory. I see a question over there.
Before I ask my questions, I want to thank you all. This has been a wonderful panel. In the last 10 years, I've been dealing with cancer, and this is the first time I have really understood palliative care. So thank you, thank you, thank you.
Thank you.
It's been wonderful. Now, my question is, like I said, I've been dealing with cancer for the last 10 years, and I became a support group leader. And now the challenges that we face as leaders is trying to engage the members. What will be something that you will give us as a tip? I know it follows that question, but as a group leader, because I mean, you are a leader, so you are supposed to lead your group. You're supposed to give them and encourage them and give them the tools so they can find the resources, but engaging them in the palliative care, because like I said, it's the stigma that palliative care is, well, I'm dying, pretty much. So just a little help.
I'm also a leader of a support group, and I think what we do with our team is we plan to see what could be the different things that the group needs. Sometimes we ask them what they want to hear, but we try to have education and support, listening sessions, because not a lot of people listen to them. One of the biggest things that they say is, we don't have people in the hospitals who listen to us, and we didn't have that support of people being accompanying us. So we try to have in those groups those education and the support to allow them just to be free and talking about whatever feeling or whatever thing they're going through. Because in the experience of these survivors, many times they cannot do it because they want to protect their families. They have religious leaders that tell them, don't feel that way. God is powerful, be positive. And they are left with a sense that where do I put my sadness? What do I do with my anger? I feel lonely, but I don't know where to go. So I always ask them what they need, and I try to give them what they need. And also whatever they don't ask, and I feel that they need, I will say, hey, we need to do a little bit of education on 5 wishes. What about palliative care? What about directives? You know, we have to be prepared for everything. What about prayer? You know, what about, you know, so I don't know if that helps.
I think another thing to think about is like sharing stories and sharing like anecdotes to people. So saying, you know, this person had a great interaction with the palliative care team and this is what their intervention looked like. Or saying, you know, I went to this panel and people talked about like these types of interventions. I think sharing those stories of what the interventions can actually look like can be really reassuring for people as well. and saying, is this something we're interested in learning more about based on these stories?
And I'm just going to give a shout out to Myrna, who is a partnership member and has done a phenomenal job in supporting the partnership and all the work she's done. So I know she has done phenomenal work doing her support groups. So thank you. Thank you for that. Is there a question, Nancy?
Yes, so there's 3 questions from virtual viewers. The first one is, does palliative care always lead to hospice, or can you be on palliative care for many years?
You can be on palliative care for as long as you want to be on palliative care, and having those services available to you. You can't hear me? Oh, sorry. You can have palliative care, and the panel can disagree with me, for as long as you want to have palliative care. And our hope is that you don't need hospice care, is that you will continue to live with your serious illness. So it doesn't mean that it has to transition to hospice care. For some people, it does, but the hope is that you'll continue to have a full life living to the best extent you can.
And some people sometimes are in hospice because of the care they receive. They get better and they have to go back to palliative care because they don't qualify for hospice.
I have kids that I know are going to outlive me, you know, that I have been to their house with their respiratory rate being 2. And then this was, I don't know, 10 years ago, you know, and I still have them. Actually, I have something that I have to do for them today, but yeah, there's no, it's too bad that it's got that connotation, because it really is more about living well than it is about perhaps you have a shortened life expectancy or whatever, but
it's about the living.
It's about the living. It's about, yeah.
Thank you. So question 2, how do you continue palliative care once the patient leaves the hospital? What palliative care services are available in the community for the patients?
Hopefully a good case worker or a social worker or somebody in the hospital will give you sources of referral and tell you, you know, you qualify, you may want to look into this, and these are the places in Rhode Island. There are certain places here that offer that, and I think people just need to be educated and being told that that is something that they can use.
Yeah. I think there are a lot of palliative care resources out there. And so talking to your physician and asking for palliative care, certainly when you leave the hospital does not mean you don't need palliative care anymore. So getting that where you can go to an outpatient clinic or have even coming into your home. There are some nurse independent practices here in the state of Rhode Island as well. So they are accessible, and I'm hoping at some point, and I don't want to put the partnership on the spot, but we will be forming a palliative care work group or reinitiating it. And we're hoping to put some of those resources out there for you on our website so that they are available to people.
Oh, that's great. Thank you. Are there any good resources the panelists can share around palliative care education that can be provided to primary care?
That's a really good question. I don't have the answer.
There's a program called Honoring Choices Massachusetts that has a lot of things online. I don't like the name of it per se, but it's called NWELL. Thus, you know why I don't like the name of it per se. But they do have a lot of resources as well. For nurses, there's the End of Life Nursing Education Consortium that does a train the trainer, as well as just doing primary palliative care education. And hopefully we're starting to initiate more of these things within the state of Rhode Island as well. So I think we'll be trying to put resources up on our website. And certainly I think Wilson had mentioned this earlier, and I shouldn't be saying this again, but I would love to do some workshops on palliative care, advanced care planning. The one plug I'll put in for advanced care planning, do it when people are healthy and can make those decisions rather than waiting until they're in the hospital and then having to make those decisions at the last minute, because it's very hard. So starting these conversations early, making them normal conversations that we're not just doing it in a time of stress, that we're really talking about what's important to us. So more resources to come, but certainly the other thing, and I will speak for the whole panel because I asked them if I could do this. Reach out to any of us at any time if you have additional questions. We're happy to answer them and provide resources as best we can.
Perfect. So I have one more question that came in. Are there educational resources available to older physicians to engage them in recognizing and understanding how to communicate to the cancer patient about palliative care services? Discussions surrounding extensive care measures taken in their specific treatment plan that now require acceptance and entrance into hospice.
You guys ask really good questions. Like, I don't know who was out there who's asking these questions. But that is a brilliant question. I don't have the answer to, sorry. I don't know the answer, but what a fantastic question. That
I guess I call them, as people want to be referred to now, as seasoned physicians as opposed to older physicians. But I do think there's Vital Talk, which is a national program that they can do. Harvard has a lot of programs. Brown has a complex conversation program that is free. So I think there are a lot of resources. And once again, reach out to me and I'm happy to give a list of resources because there is a lot out there. Some are for pay, some are for free. And as for me, I'm happy to talk about palliative care anytime. So I would just say have people contact me.
I'd also add to, the physician obviously is, who someone is working with most in the community, but not all physicians work completely independently. So even if they have a nurse who's easy to engage in this conversation, or a social worker in their office, or if there's a chaplain in the community who's willing to facilitate a conversation with a physician, kind of look at the people who you do have in your lives who might be willing to serve as a facilitator or a liaison to kind of have that conversation with a physician for you independently, I think is another kind of potential option.
Great point. And any other questions? I would also just add a last thing, anybody can have these conversations. Of course, we want the physician to be initiating these conversations, especially when prognosis is involved, but that's why it's a team. Certainly, we all have unique skills and qualifications, but we're also complementary, and that's why palliative care, once again, I could talk about the values of palliative care all day, but it is interdisciplinary because we recognize that we can't do it all alone, that we really do need this team approach to address those multiple needs or multiple dimensions of the person. So start these conversations, spread the word about palliative care. I think people need to be educated on what palliative care is and destigmatize that it's only end-of-life care because it really is living care. So thank you. And thank my panel. My panel has been phenomenal.
So easy enough for me to say thank you, Susan and Laura, Angie, Wilson. It's so good to see a panel of experts on palliative care and the ability to talk and clarify it for us. And now it's up to us to take it out to the community, which brings me to my last points. As Susan mentioned, the Partnership to Reduce Cancer in Rhode Island does have a palliative care work group. We happen to have the expert right here as the chair of that committee. So we're hoping, after hearing about whole patient care from psychosocial and medical and nursing and spiritual, that maybe some people have some energy to say, hey, that's a field that I think I could really help and promote and join the palliative care work group. So thank you all for that.
Are you okay?
A couple of last announcements as we finish up today's wonderful summit. I know you're probably tired of listening to me, but just a couple more. First, I want to give credit and thank Amica Insurance for they did all of the printing for this, and they've done that for many, many years. So all of the photos and everything about the partnership in that and all of today's activity that's in print came to us free from Amica Insurance, and they've been a partner with the partnership for a while. So thank them. We thank MDR Communications for all the technical assistance they provided in the back table. Thanks, Mike and Andrew. Lee. Okay. Where'd she go now? I always lose her. What?
Who are you looking for?
Looking for Ashley Aragonis. You've all met Megan, who's the executive director. There was a young woman at that back chair. Her name is Ashley Aragonis, and she is actually the community outreach coordinator for the partnership. So I just, if she comes back in, I'll make her stand up. So we'll do that. If you like today's summit, I can't encourage you enough to join the partnership. You can join it as maybe you want to be in another work group. Maybe you just want to attend meetings, quarterly meetings, want to attend the summit. However you would like, you can get on the website and sign up for the Partnership to Reduce Cancer in Rhode Island. We're always looking for help. Diane? Oh, yeah. We only have one more opening, and to join is free. All right. We're looking for people who are willing to participate and help as we try to, you will read the mission statement in the folder. As we try to accomplish that mission statement, if that's something that appeals to you, please join. Finally, evaluations. This is kind of the part where everybody, when you were a student and you said, oh, is this going to be on the test? Okay. No, now we say when we're students and when we're professionals, how do I get my credit? You get your credit by the fact that we will send you an email immediately at the end of the summit. Okay, you'll get that email on the email site that you registered for the summit. Please fill that out and evaluate how the summit went for you. For those of you looking for CEUs, after collecting those evaluations, they'll be sent out your certificates by email. Okay, so you'll get that back on your own computer. You can print it out or leave it on your email, whatever is easier for you to get your credits for your recertifications and reaccreditations. There is, for nurses, a post-test at the end of the survey. That's not required of the general audience, but nurses, you know how your CEUs are, and you always have to evaluate a program. And so we needed to do that for nurses specifically. So if you are an RN or a more advanced practice nurse and you need that credit, please, please fill out all of the evaluation and then the survey that's at the end of the survey. Okay, so with that, I want to just say thank you. I'm glad you were all here. It's so nice to see people in person. Thank you for all of you who attended by Zoom, and I hope you enjoyed it as much as we did here. So thank you very much.